Sheetal has to change her background. It's IIRSA is coming.
Oh, good evening. Yeah, I'll do that.
Hello, Sheetal.
Hello, ma'am. Hi, everyone.
Hi, Sheetal. Hi.
Hello. Hi, Kavita.
Hi, Dr. Sheetal.
Hello.
We are live. Please.
Yes. Shall we start? Shall we start?
Yes, ma'am.
Very good afternoon to one and all of you here. We are back again with our ARC webinar on complexities in cataract surgery. I'm sure if you have looked at the panel list, we know we have the best of best here. Our expert panel, Dr. Mahipal, our president of AIOS, Dr. Ramurthy, our past president, and our general secretary, Dr. Namrata, are going to lead us through with their very valued points. We have the very best of speakers who will be showing us the very challenging moments of cataract surgery with a pearl of wisdom for each of them. So without ado, we shall now go on to introducing our first speaker. Dr. Srinivas will do the honors. Dr. Srinivas.
Good afternoon, everyone. Welcome to the ARC webinar on cataract and its complex surgeries. So the first speaker I'll be introducing is none other than Dr. Ashwin Agarwal, who's the young, dynamic, and I would like to add the word handsome, star of Agarwal Group of Eye Hospitals. He's the Executive Director, Chief of Clinical Services, and the Chairman of Clinical Board. A surgeon who would like to take on the deadliest of challenges and absolutely unique, and he's very innovative in his approach. So now, without wasting much time, let's watch his surgery and learn more from him. Over to you, Dr. Ashwin.
Thank you, Dr. Chitra. Thank you, Srinivas, for this wonderful webinar. I think I see a stalwarts of ophthalmology here. So thank you for organizing this, especially on a Sunday afternoon like this. I think the topic today, which I'm going to talk about, is how do you combine cataract surgery in these traumatic / complex scenarios. And if you see the case here, it's a primary surgery that was done before, where there has been corneal tear repair, as well as nothing else from this thing. But if you see the injury, there's an intermittent cataract, as well as we don't know the status of the capsule. We know that the iris is completely torn from pupil to root, and we need to somehow repair that. So let's take this step forward. First up, we're removing all the loose details. What I'm trying to do here is first analyze whether I can use the bag itself. And in order to do that, you really want to put some trypan blue inside the eye. Once you put some trypan blue and wash it off, your adrenaline here will not have any impact. So really don't want to use any adrenaline in these cases. But when I was trying to do my rhexis, I realized that the bag in that site of injury had already been ruptured. So basically converted it to a hybrid of CCC and can opener. Once you finish with that, this patient, being a 27-year-old patient with the nucleus and the cortex and the lens material came out very easily. But I could see also there's a thick fibrous band that extending from the posterior capsule all the way to the corneal wound. And I tried to magnify that with as much as possible. And I used an endoilluminator, which I always use in order to visualize. So that's one of the best tricks that I can tell you for everybody, to use an endoilluminator intermittently whenever you need. And when I did a vitrectomy and I released that fibrous band that was extending, I could see vitreous come all the way. Plus, I didn't have an anterior capsular rim. So I really knew that I had to move to a plan B in this scenario. My plan B was using flaps and using a glued eye intraocular lens technique. Plus, if you see the bag here, it's not a very clean bag. The minute I remove that bag, the whole view becomes very, very clear. I always like to do a posterior vitrectomy as well in these cases. We never know what would have gone in, if there a foreign body, which probably was not shown. I always go to check that. I'm not going to show the glued intraocular lens technique so much because I think there might be other topics for that. But I'm trying to see what are the methodologies that I'm using to treat this condition. Because the condition here is not about implanting the lens. You could have implanted a Yamane or any of the intrascleral haptics. In this case, you probably could not do a ACIOL or a iris fixation in this case. It may not work because of the lack of iris support. But what we really need to understand here is how do you handle this iris root /pupillary tear. So basically what I'm trying to do here is first join the root of the iris. I mean, that's where the main crux is. I mean, a lot of us will probably go for the pupil side. I've always suggested to go for the root first. If you try the roots together, then you understand the extent of the wound. And that's when the iridodialysis kind of comes into play. And then you start understanding how do you take care of that iridodialysis. Otherwise, you'll just be ending up doing 2 or 3 iridodialysis repair, which you don't want to do. So I'm using a single pass 4-throw pupilloplasty technique at the root of this iris, not at the pupil edge, not at the leaflets of the pupil, but at the root of the iris. Again, I repeat, the root of the iris is what I'm treating first. Once I'm done with this, now sit and understand what the extent of this wound, of this iridodialysis is. If you see here, now I'm able to realize that there is almost a 5 to 6 clock hour iridodialysis repair. Now I already have glued intraocular lens flaps, which I can use to do a hangback technique. And that is what I'm planning to do, a double arm 10-0 Prolene. I mean, you can use a 9-0 as well. In this case, I used a 9-0 because they are a little more visible than the 10-0. So Prolene suture through the same wound. Once you have that loop going in, it will actually pull that whole iris tissue or the root back towards it. You already have the flap, so you don't really need to make Hoffman's pocket or anything of that sort where the sutures can get hidden. Once you're done with this, you really can easily see that this optic edge is actually visible. Now, I'm a sucker for a little bit of this edge, you know, that it causes some form of visual disturbance post-operatively. So I always like to leave that leaflet as the pupillary leaflet, as I said before. The pupillary leaflet actually helps close that optic edge. And now once I'm doing a single pass again, so I did a single pass, then I did the iridodialysis, and then I'm doing a single pass again. So that's the methodology that I use to actually overcome these. And and this is the post-operative day 1 of the same patient. This is day 3. And here is the 3-week post-op 20/30 vision of this patient. Was very excited, very happy, especially when it was left for 3 months without any support or any help. So this is my case, and I think small pearls that I had given was what I wanted to showcase to everybody here.
Wonderful video, Dr. Srinivas.
Yeah, wonderful, Dr. Ashwin. It was really, I think your video was much better than the animation. So it was a perfect video. So just I wanted to ask you, in which cases do you prefer, of course you can do, in what cases you can go up to 4-throw pupilloplasty? How many area clock hours of iridodialysis you can repair it, and when you can give it up and go for anaridic SFIOL? Or do you prefer anaridic SFIOL at all?
Okay, so if I'm getting right, I would do I'm not talking about single pass because that's a pupillary repair. But if I have to do the root repair or any of the iridodialysis repair, I would do a hangback or a sewing machine technique based on which side it is. If I see the nose bridge coming in, then I would always move to the hangback because that's an easier technique. If there's no nose bridge, then I think it's easier to do the sewing machine technique. These are the 2 techniques that I use for iridodialysis repair. In terms of extent, anything up, I think I would use it even if I have only 3 clock hours of attached iris. I would still use a iris root repair. I delay as much as possible from aniridia IOLs. And in aniridia cases, I obviously use aniridia IOLs. I don't tend to use much of aniridia IOLs. So,
and your preferred is always the glue type of IOL implantation, is it?
Yeah.
Or the other technique?
In these cases, so the reason I prefer glued intraocular lens is it's a lot more forgiving than any other technique in terms of titration of the IOL, titration of the centration of the IOL. All those things are much easier once you have done it. I mean, it does require you to know anterior vitrectomy. It does require you to know infusion cannula insertation. You need to insert an infusion cannula. If you have these basic out of the way, then I think glued intraocular lens gives you all that comfort which you really need, or the margin of error.
And I love the way you also did a vitrectomy for that cases, because in these cases, many of the times we see these cortical droppings happening over and they come up with a post-op uveitis, which we keep watching again and again. I think it's better to check inside what is happening, and do more vitrectomy, I think, is a wonderful idea.
Yeah.
Expert panel, do you have anything to add?
I just want to ask one question, Ashwin. Excellent case, done very well, quite complicated. I just want to know if there's an anterior capsular rim which is present all around, which was present. So would you not think of putting the lens in the sulcus?
Okay, fantastic question. But unfortunately,
another thing is that iridodialysis repair in this particular case, in the area where you were, doing single pass fourth row and making a single pupil, chances of glare from that region would be less, because that was also the area of a linear scar on that area. So unlikely that, rays would transmit through that. But I think you would have answers to both these questions. So
no, absolutely. So I've done a few cases where we have left that scar, and hopefully in the hopeful side that that pupil will not this thing. But if you saw when I finished my iris root repair as well, there was an edge of the optic which was clearly visible. And I feel that the edge of the optic, leaving that edge of the optic like that, has had visual implications to it. And I probably would not have got 20/30. I probably would have got a 20/50 or lesser than that kind of vision. In that respect, I think a smaller pupil has always been a little more beneficial. That being said, I think the first question was, if you saw what I was doing in the beginning, I told I was using a hybrid technique of a can opener and a Rhexis format, because the anterior capsule had already been torn at the site of the primary injury. And if I completely agree with you that if there is even a little bit of the round of the anterior Rhexis left, even if I'm doing a glued intraocular lens, I would leave that in place, because that is the one aspect, that anterior capsular rim is the one aspect that prevents any optic capture from happening, any optic from coming above the iris. So I always tend to leave back as much of anterior capsule tissue, not the posterior capsule. Posterior capsule, take it off, no issues, because you're doing a glued intraocular lens. You're going behind anyways. But the anterior one is a vital one, and I think I'm glad you brought that up, because that's a very important, interesting point.
Thanks, Dr.
I have a couple of comments linked to what Namrata just said. In the sense, exquisite surgery, Ashwin, but I had a feeling that even there's adequate amount of posterior capsule, especially when you use the endo illuminator, there was a fair amount of posterior plaque that was seen. Of course, that would have obstructed the vision, but whether you could have used that to just put a lens on the remnants of the bag itself. There is, of course, an anterior capsular remnant on the side where the iridodialysis was there, was quite inadequate. The other two comments is that one is, of course, the corneal opacity, which would have helped to obviate the glare. And something which I had mentioned before also, because I have burned my hands badly once. That is when you're doing this fourth row pupilloplasty, which is an excellent technique. I always make it a point not to pass the 26 gauge needle through the leaves of the iris, because sometimes that tears up the iris quite significantly. So it's a good idea when you're railroading to pass the straight needle, the 10-0, the 9-0, the 9-0 through the leaves of the iris, and keep the 26 gauge needle outside. I saw in one of the leaves you're passing that. And I have done that in a couple of cases where I had a fairly large tear of the iris. Since then, I have stopped doing that.
Excellent points and observation. I think the first point on the capsule, anterior capsule, I was pretty sure on that, on the side of the tear, the corneal tear, the whole anterior capsule was completely ripped open, and I couldn't see the extent of it, number one. The second point is, as soon as I did see that vitreous brand that was coming from the posterior capsule all the way to the corneal wound, the minute I cut that open with using a vitrectomy in the anterior chamber, I actually saw vitreous come up. And that's one of the reasons why I had to actually go ahead and do an anterior vitrectomy.
No, you definitely had a PC Ren, but I was just wondering, because looking at with the endo illuminator, the kind of PC intact PC plaque, vitrectomy was indicated, but whether you could have used that posterior capsule to place the large optic IOL. Anyway, this technique works well in your hands.
Yeah, I guess it's also surgeon's choice at times. Yes, Chitra, ma'am. Yes.
Yeah, I think we should go on to our next speaker.
Sure.
Our next speaker is our most eminent and ever approachable Dr. Ashok Grover, our past president of ARS, a world-renowned oculoplasty surgeon and a teacher of par excellence. He has a very practical tip to share with us, and I'm sure there's going to be good discussions which is going to really help our audience. So on to you, Dr. Grover.
Thank you, Chitra, for your very kind words. And I hope the screen share is working fine.
Yes.
So we are meeting on the day when it is Guru Purnima. So a nice day to remember Sushruth, the father of surgery and cataract surgery on this day, before we go on to this video. So this is a video which will be presenting my options and the technique, the options that you have when your rhexis gets broken in a radial fashion and you have a hard cataract in front of you. So it started with a very routine surgery in a mature hard cataract with topical anesthesia, temporal incision, and we are doing a staining because it is a white cataract. And then we proceed to do, it's a hard, totally nucleus grade 4 to 5 cataract. So we are starting with a relatively small rhexis, thinking of a possible raised intralenticular pressure and more cautious approach, small bites and small extensions of the rhexis gradually all around. So this is about 4 at this moment, 4.5. And by the time we reach the end, we decide that we can spiral it a little, and we go on to increase it a little to about 4.5 to 5 millimeters. We are spiraling it and completing the rhexis. Now at this stage, we are reasonably satisfied with our rhexis, and we do a hydrodissection through the main port with a small syringe with a backward pressure, but it seems that at this moment something happens. Sorry. So at that moment, the capsule has snapped. So this is the moment we are pushing in the fluid and the capsule snaps. So now we have to think of our options. We now have a hard cataract. We have an extension which has happened radially. Fortunately, it is not for my 6 o'clock. It is at horizontally, which gives me a little breather. And I feel reasonably confident that it is not extended backwards. I'll check with a little rotation. It is rotating well. So I think that if I proceed cautiously, I can possibly go ahead. And then I think of the options of doing a direct chop or doing a stop and chop. And then I decide that I would do a stop and chop and keep the forces of breaking the nucleus away from the area of the break. So I begin with a little rotation to check that there is a good stability of the nucleus. And I decide to go ahead with the phacoemulsification by stop and chop technique. So all that I want to do now is to make a really deep trench, so that when I separate the nucleus and break the posterior capsule, the posterior wall of the nucleus, that's the most risky part, when I would use either centrifugal forces or increase the intralenticular pressure enough to cause a break, the break to extend. So I go at multiple points, go to the full depth of the wound, and then do a separation of the nucleus. It is fairly hard and breaks with difficulty, but when I do it from multiple points, I have succeeded in separating it. The movement is good. I'm all the time checking for any signs of instability, a sideways shift or difficulty in rotation. And then as you see, my forces are being used on the right side with my phaco probe, rather than I'm trying to minimize the force that I use for separation with my vertical chop on the left side where the break is. And here, as you can see, I'm lifting it forward. I'm going to emulsify the pieces in the iris plane. And I started debulking from the beginning. Rather than leaving the pieces in, I'm lifting off the pieces to debulk and reduce the intralenticular pressure. So once the first half is done, I'm proceeding with the rest, making sure that the chamber remains deep. My parameters are not too high, and I'm trying to not use any more forces. Now that it is debulked, the forces in the bag will reduce in any case. And I'm bringing all the pieces anteriorly, and in the iris plane, I'm removing the fragments. So reduce the parameters further for the last piece and went ahead and removed this last piece as well. So we're so good, so far so good. You can see that things are okay. And then I do my IA, staying away from the broken rhexis area till the end. I'm used to coaxial, so I do my coaxial, even though the other option is equally good. And now that things are stable, I will deepen the chamber and put in my lens. This is a single piece lens, which is preferable because the haptics will be softer, and I will keep the haptics away from the direction of the break of the rhexis. And well, I've succeeded. This has worked, but you need to be cautious and take all the precautions that we spoke about in order to weigh your decision. Your experience with these surgeries should matter. How you've done in the past should matter in taking a decision whether to convert or whether to go ahead and do a phaco in a hard cataract with a broken rhexis.
Thank you very much, Dr. Ashok. It was an excellent teaching video. What was the best thing for us to learn is the anterior chamber stability, which he maintained throughout the procedure, and also the plan of putting a single piece IOL in these cases of a rib, because a 3-piece could have ripped the caps rhexis more. But the probable reason why he got this rip happening in the first place was having a smaller rhexis in a harder cataract, and also possibly did he forget to decompress, because of which the intralenticular pressure became more. And the other thing is, I want Dr. Rohit also to comment. He had the flap was everted. So based on Dr. Rohit's theory of the flap motility sign, so an everted flap is an indication that the extension would not be there. So Dr. Grover would have had a more comfortable surgery. So Dr. Rohit, you have anything to add here?
I think it was a perfectly planned surgery using the safe phacoemulsification technique. I think his pulse would have been on the lower side had he just concentrated on the flap which was extending to the periphery. All throughout the surgery, using the safe phacoemulsification techniques, the flap was everted and fluttering. That was conclusive of the fact that it was pre-equatorial, and otherwise everything was perfectly done.
Our expert panel, do they have anything to add?
I think it was a very, very good case and good teaching things in it. The only thing is that I probably would not have done a trench, would have done a direct chop. Two is that the chop, while rotating, I wouldn't probably go through the left side, but I would rotate on the right side, because on the left side, the torn rhexis was already there. And I think we all can take a call on it, and we do implant single piece lenses in torn rhexis, but I would be more comfortable with a 3-piece lens rather than a single piece lens in this situation. And I think one more thing that needs to be...
Why a 3-piece? The haptics would be more rigid. If you're planning to put it in the bag,
I would put in the bag, but perpendicular to the area of the torn rhexis, a 3-piece lens. But I think that's the individual discretion. If you want to put single piece, you can put single.
I would be much happier with a single piece.
But the orientation would be perpendicular to the area of the torn rhexis. And another thing I think which was not highlighted, probably edited out, was that whenever you take out your instruments in these cases, it is imperative to put viscoelastic from the other side port, because when you are taking out your instruments in that maneuver itself, sometimes it can just go back posteriorly.
Yeah, I did mention that maintenance.
I think, excellent teaching video, Ashok. I mean, I only feel that it emphasizes the fact that most of these hard cataracts elderly are associated with very friable capsules. And I have had an occasion when at the final hydration of the wound, the capsule gave way. So obviously, you did only very gentle hydrodissection, but decompressing and using very small aliquots of fluids is extremely important. Absolutely. I personally would have maybe avoided rotation in these cases, because in these total cataracts, very often when you go ahead with the rest of the phaco, it they freeze up the nucleus. And the fact that your tear was at almost I hope everyone noticed that he split the nucleus at 90 degrees to the orientation of the split. in the rexus. That's extremely important. That transmits the minimum amount of energy in the direction of the rexus. And as Namrata mentioned, obviously you would have used a lot of dispersive viscoelastic to keep the AC formed as well as protect the corneal endothelium. And in these cases, I wouldn't have preferred doing more of anterior chamber phaco, even though it's a hard cataract, so as to not to stress out the capsular bag to the minimal extent. Otherwise, a beautiful case.
Ramamurthy, I would have possibly converted my break in the rexus was radial and at my 6 o'clock. Then it would have been a more difficult surgical.
It was the most graceful surgery we watched, Dr. Grover. I really liked it even when I watched it the first time. Dr. Dhami, could you do your screen share? A lot of pearls learned from your video.
Yeah. So now next, I think, yes, ma'am. Can I introduce Dr. Dhami?
Yes.
Yeah. So next we have Dr. G.S. Dhami, who we all know is from Ludhiana and director of the Dhami Eye Care Center. And he's an amazing cataract and refractive surgeon, the president of IRISI, and a lot to learn from Dr. Dhami's video. He'll be sharing his video on intumescent cataract. Dr. Dhami, can you unmute yourself?
I think there is a video in this and it is not, the audio is not coming.
Yeah.
Dr. Dhami, can you talk?
Admin, can you check what the video?
Can you unmute him?
I'm trying, he's not responding.
I think sir has to unmute. Can somebody call him up and tell him?
Yeah.
Yes, sir. Ho gaya. He is unmuted. Sir.
Dhami, can you talk? We can't hear the video.
Sunil, the video is playing from Dr. Dhami's side or from your side?
No, from Dhami's side.
Okay, then I think we need to tell him that the video is not heard.
Dhami sir, can you hear us?
Can you, play it again? Unmute yourself, please. Play it again. Dr. Dhami, you can play it again and keep yourself unmuted. You could start talking.
The video is muted, actually. You can see that the video is crossed here. The audio is crossed in the video. So either that has to be uncrossed.
You could uncross your video?
Yes.
Sir, you need to unmute yourself, sir. No, there is a button, there is a mic button, no? So you need to unmute yourself.
I think isme na volume hoga, which is on the 0. It has to go to 100. If you click this button.
Dr. Dhami is muted as of now. He's not responding.
He did take it to 100, Namrata. He did take it to 100 and then back again. He's trying to work it out.
Dr. Dhami, shall we sort out your problem and have the next speaker presenting till then?
Ma'am, Dr. Dhami needs to unmute himself. He's muted. I'm trying. He's not responding.
Oh, he spoke to me. Hello?
Yeah, he's unmuted now. He's muted.
Dr. Dhami?
Dhami, sir? Yes, that's fine.
Sir,
please share your screen, sir.
Sir,
please
we can play the video again, sir.
Yes, perfect.
No, still muted.
No sound.
No, it's fine.
I'll speak it myself,
Yeah.
See, whenever you have a white cataract, you nearly get attention in a pre-operative workup that what is going to happen. Whether I'm going to have a good rexus or I'm going to default and have an Argentinian flag or complete the phaco or convert. So we thought over doing an anterior segment OCT in every white cataract we have. How does it help? It really plans a very comfortable surgery for you. Once you do a preoperative AOSCT, we look for a fluid spaces in the cataract. It virtually takes your heartbeat to normal if something like this you plan happens. Moment you put your access forceps in, you are having something which you never wanted. Can we prevent this? Yes, we can. Have a good workup of your white cataracts. Take it to an anterior segment OCT, plan it. Once you have an anterior segment OCT with you, you can easily decide what is going to be the course intraoperatively in the OT. Your nerves will remain calm because you know what is going to happen. See, we stain. We already know that this cataract has a fluid spaces into it. If you see the markers, there's a good subcapsular fluid space. We go into the AC through a separate port with a 27 gauge needle, aspirate the fluid from the space we had seen on the anterior segment OCT. It is very well planned at this stage, no fear and nothing to worry. Everything will go as you want. We have removed the fluid, and once the fluid is removed, which was known very well in advance, we could easily perform the rexes. This is the second case in which we maneuvered it with a 30 gauge needle a little away from the periphery, a more comfortable position to take the fluid in. And once the fluid is drawn out, we have a very comfortable position to check how comfortable look we have now, which would have already identified before we could go into the surgery or planning the surgery preoperatively. A very good job and a perfect surgery. Now this is the second case where on anterior segment OCT we see no fluid. That means we can jump, go fast, do a rexis without a fear, a comfortable position. I think nothing could have been so softening to the surgeon to know beforehand whether he is going to have a chance or whether his surgery is going to be ruined. A simple test, a preoperative workup managed everything. Thank you.
Thank you very much, sir. Can you just stop sharing your screen, sir?
Yeah.
And I would like Dr. Suhas to share his screen while we are discussing Dr. Dhami's video so that we don't waste time.
Yeah. So I'd like to ask Dr. Grover here and other expert panelists here that what is their technique in cases of intumescent and Morgandian cataract? Do they also prefer to do anterior segment OCT in all those cases? And how do you plan? Dr. Grover and other expert panel, please. Grover, sir. Please unmute yourself, sir.
Dr. Suhas, can you?
Okay. Can you hear me now?
Yes, sir. Yes.
Okay. We don't really do any anterior segment OCT, but from the appearance, from the milkiness, from the swollen lens, you can often infer whether there is going to be a positive pressure or not. And you have to be mentally ready for the positive pressure. And of course, the other precautions are all very well known to us, making sure that you use a high viscosity viscoelastic, keep the chamber deep, make a small nick at first, let the fluid come out. So all those precautions, all the innumerable modifications that have been suggested for tackling those with a positive intralenticular pressure. And this is a very good technique which Dr. Dhami has presented. If you see fluid, decompress it. And I think that should work quite well. In other cases, you can use any of the different techniques that have been described, including use of a phaco probe first to make sure that you get out some fluid from the lens so that your intralenticular pressure decreases, or any of the other methods for decompressing the intralenticular pressure. So it works well.
I think
Namrata ma'am.
Yes, I would just like to say that I think hats off to Dr. Dhami sir for an excellent concept and an excellent video. And I'm sure and I'm confident that AS OCT is going to become, routine investigation now even for lenses. And if you look at the anterior segment OCT, the KCR2 has the maximum amount of resolution. And for all our posterior polar cataracts and for our intumescent cataracts, we use that because that can really pick up, cortical fibers, lenticular fibers, fluid, etc. And of course, like I always say, intraop OCT of course helps, but ASOCT preoperatively is extremely useful in cases of white cataracts.
We do have the ASOCT, and I completely agree that it's a great tool to assess, but then just in case you don't have access to it, a good preoperative assessment itself will tell you, most often after dilatation, if you look at do a good slit lamp examination, then you can see fluid clefts, or whether it's a fibrous capsule, in which case you feel it's a shrunken cataract you're dealing with. Another great pointer is the AC depth. It is beyond 2.83 millimeters, then it's unlikely to be an intumescent cataract. You can see the curve of the lens bulging forward. And of course, the crowding of the angle of a good gonioscopy. Just in case your ASOCT is no doubt a great tool, but you can get a very good idea preoperatively by doing a good clinical examination also.
Dr.
I have two small points to share, if I may.
Yeah, please. Sir.
Yeah. So the excellent surgery, this needle technique, which is getting very popular these days, that in an intumescent white cataract, you use a 26 gauge bevel needle and introduce it into the lens and suck out the cortical matter to decompress the bag. Right, that is working very well. But there was a discussion whether the bevel should be facing upwards or the bevel should be facing at the back. So doing both the techniques, we realized that if it is facing back, as you suck out the cortical matter, the anterior capsule does not come in touch with the needle, and there's a risk, there's less risk of the anterior capsule actually getting punctured. So bevel down works better. And the second thing which we noted was that in an intumescent cataract, it is known that the maximum pressure is in the center of the lens.
Absolutely true.
So if you enter the lens from as much peripheral as the incision and your iris permits, and then enter, at that point the pressure is less, so you can easily suck out a little bit of material, decompress the bag, and once the bag is decompressed, it is very easy to make a small rhexis, and then you can extend it further.
Can I add something, Dr. Chitra? Dr. Chitra, can I add something?
Yes.
I think a wonderful surgery, Dr. Dhami, as usual, and I tend to agree with Dr. Sanjay. We've been doing a lot of cases of intumescent cataracts from all my centers. I'm trying to accumulate and do them. I have recently described a technique called the reverse T or inverted T. I agree with Dr. Sanjay. If you go with the bevel up, the chances of you yourself cutting the capsule when the suction comes on is higher. Number two, very important point is the capsule in the centermost part anteriorly, and the most posterior pole is the thinnest. And the capsule is thickest between 5 to 7.2 millimeters approximately. So if you go with your bevel down in the mid periphery at the junction of central 2/3 and lateral 1/3, that's the time, even if you puncture, even if there's a very high interlenticular pressure and the puncture is linear, not radial, the chances of it tearing out are very, very minimal. We've done hundreds and hundreds of cases. We are publishing a case in the series in JCRS. So I agree with Dr. Sanjay. The bevel has to be down. It has to be away from the center, in my opinion.
Very good. I think for the paucity of time, I want all our speakers to get a good chance. We would go on to our next speaker, Dr. Suhas Haldipurkar, whom we all know is a prolific surgeon. And amidst all his glorious achievements, what is most important for us to remember that there's some sheer magic which he has in his hands. And we are going to be seeing it through his surgery now and the wonderful teaching pearls. I have always felt that he's one individual who has his hall bursting with attendees when he conducts an instruction course, because he has a flair and a style of his own and a lot of learning. So on to you, Dr. Suhas.
Thank you so much, Chitra. And on this Guru Purnima Day, my pranams to every one of you. You have been wonderful. Now, this is basically a teaching video for someone who's in the early stage of his phaco. And what mishap you're going to see now is something many of us at some or other stage get, especially when we are in the beginning stage. Now just watch it. And you will notice that there are so many flaws that are accumulated in that very small movement. And naturally, now this is done by a resident, and I was mentoring him, and I just happened to be on the microscope. Now, this is a time for us to freeze and think. Now, if the resident knows before the surgery what all are the complications that can occur, and if he knows the steps, he's in a much better position. And as you can have to watch again, because not very often, but having looked at it, now you know that that is what you would definitely expect. Because here, the phaco tip is not properly occluded by the nuclear fragment. Your two instruments are not working together. Probably the surgeon's understanding of phaco-dynamics is still not that good. His hand-foot coordination yet to improve, and foot switch control is still to get fine-tuning. Now, what is it that you do? As a surgeon, you would freeze here. You would get your second instrument out and get your viscoelastic in. Obviously, the viscoelastic is a dispersive viscoelastic. And once you have done that, the moment your cannula goes in, your irrigation stops and it tries to block that particular defect in the posterior capsule. Now it's time to assess. Now there are certain things which are in favor of the surgeon. We are almost at the end of the phaco and there's only one quadrant left. And the rupture is a small punched out defect with minimal vitreous disturbance. Now, both these things tell you that with good viscoelastic blocking the vitreous, you can always take care of a lot of loose cortex which is still there. Very often I have felt that if you rush in with your cutter, sometimes there's a possibility that some of the cortex can get dropped in. Now, having made sure that most of it is out, the next important thing is to assess how much of vitreous is in the AC. And with a high cut rate, you would go and with very low vacuum, just go near the opening. And the good part is the opening is well circumscribed. And once you have made sure that there's not much of vitreous and the opening is clear, you push in some more viscoelastic after aspirating a little bit of cortex which is there. And then it's a time to assess how do I go about. Now there are two ways to go about. One could just use dispersive viscoelastic, block that opening, go with the phaco with renewed phaco parameters and take care of that fragment. Or one can use the scaffold technique. In the past, we would do sheet glide method, but today you can use a lens. Here, I prefer to use a single piece lens. And the lens is first put into the sulcus. And the nuclear fragment is brought into the center. And you just go about as normal with your usual parameters because you always have a lens there to protect it. And by the time your nucleus is taken care, the pupil has come down. And since the PCC, which is naturally that has happened, would let you use your lens in the bag, it's time to inject epitrate or some way to open up your pupil because obviously you want that single piece in the bag. Somehow you manage to get one haptic in, but the pupil, it will be difficult with a poor visibility to get your second haptic in. So what naturally you do is use your hooks in one quadrant to open up and get some better visibility and get your second haptic in. And all this I could do because as luck should have it, the opening was small, circular, and well subscribed. Now, one thing we have to remember, when a resident, hands over the case to a mentor and is a part of this completion of a case, He has learnt it immensely. So next time, if he gets into this problem or another problem, he'll be able to do it. So this is a small thing that I thought I would share with young surgeons who are in the early stage of taking. Thank you so much.
Actually, Dr. Suhas, that was just a wonderful video. And just for the sake of argument and a different thought, I'm going to ask these questions, although I felt it perfectly done. Now, sometimes at this point, that small peripheral PCR could become a little larger. So is there any point in having considered a pars plana vitrectomy so that that size of that PCR remains the same?
Yes.
Now, the second question I have, I want you to answer both.
Yes,
sometimes it makes sense to place that IUL scaffold a little earlier because sometimes that small piece could go in suddenly. Your thoughts on that?
Well, now this is an old clipping when trocar concept was not there. Today, if this case is to be done, I would certainly go pars plana. And pars plana is a much better way because with minimal vitreous disturbance, whatever little vitreous, if at all it has come into the AT, will be taken care. And talking about, using the scaffold little earlier, it's my practice that if possible, easily get most of the cortex from the area away from the defect before the lens is in. Because once the lens is in, it's little cumbersome to get the cortex anteriorly, and posteriorly to get the cortex as well as vitreous is a little more extensive than otherwise.
Dr. Sonu Goyal, do you have anything to add at this point of time?
Dr. Suhas, can you stop sharing your screen?
I'm sorry.
Dr. Sonu Goyal, are you there? Yes. My expert panel, do you have anything to add here?
Yeah, can I put in one small point here?
Comment.
Yeah, Dr. Chitra. Yeah, sorry. Is anybody
Dr. Rohit,
speaking?
can you just stop it for a
No, I'm
moment?
not. I'm just put it
So
on.
can I make a small comment here, Dr. Chitra?
Yes, sir. Please.
Yeah. See, this concept, excellent surgery, Dr. Suhas, but the concept of putting an IOL as a scaffold, a time-tested technique. But we realize that when you put an IOL scaffold, then any cortex material under the IOL becomes difficult to take out. Right. And then a better way we realized was to use a bandage contact lens as a scaffold. So we take a bandage contact lens, which is say about 13 or 14 millimeters in size, cut it down to a size of about 9.5 and inject it with an IOL injector. It opens up on the iris. Place the nuclear pieces on it. It's a perfect concave surface upwards, thin. You have a lot of space and you can remove the nuclear pieces with no fear at all. And then you can take it out and remove all the cortex comfortably.
Yeah. I think, Dr. Chaudhary, this was described years back by Dr. Kiki Mehta also, if I'm not wrong. He also described the Hema boat technique. Yeah, if anybody remembers. Yeah, that's another way, I think. Yes, sir. Ramamurthy sir wants to add something.
Yeah, Suhas, great video as usual. And I think the way it was managed. Maybe one other concept I would like to emphasize to the residents is that he was literally chasing the fragments. Maybe if he had kept his phacoprobe right at the center and allowed the nucleus pieces to flow in, this complication could have been avoided apart from the other factors that you mentioned. Other thing about exchanging the IA cannulas in the vitrectomy, nowadays with most of our machines, we have this, with the vitrectomy cutter itself, we have the cut IA and the IA cut. So, with a good vitrectomy cutter being used as an aspiration cannula, you can do both the vitrectomy as well as the aspiration of the cortical matter at the same time, especially when you're not going through the pars plana and do this. Otherwise, of course, an excellent technique. And I would go for a 3-piece lenses in these situations. Of course, you are a master technician, master surgeon, so you can manage this. But whenever in doubt about the competence of the posterior capsule, about the visibility, I think a 3-piece lens, the only disadvantage is you have to enlarge the incision. Otherwise, the optic material is nearly the same. And you can leave it in the sulcus, you can leave it in the bag if you're able to get in there.
The only reason single piece was put was that I was so sure about that circular punched out opening, and which was seen actually. And subsequently, the pupil came down, and that's the reason I had to use hooks to open it up.
Yeah, that was a very graceful step. Thank you very much, Dr. Suhas.
Just add one question, ma'am.
Yeah, you can.
Yeah, Dr. Haldipurkar, yeah. Just in case, by chance, while you were injecting the IOL, suppose that small punched out PC rent had expanded and had increased, then what would you do, sir?
Well, for a clean circular opening to expand, it's little
just in case, just a hypothetical question, then maybe you would place the haptics in the other way and done a reversed optic capture or something.
If I notice this even before the lens is fully in, I would probably do it with a 3-piece lens.
3-piece, yeah.
But I was so sure that once you rest your fragment onto the iris, that's a much safer place for the fragment to stay. It doesn't really fall in. And of course, with a PCR, if it goes slightly, unexpectedly larger, I think I'm very uncomfortable putting a single piece. I would always go for a 3-piece.
Yes.
I think it was the most elegant technique of, the way you put the nylon hooks and then from the sulcus, you put the lens inside the bag. I think that was very elegantly done.
Great surgery, sir. Great.
Yeah, I think you must have taken over at that point in time to.
I was happily, luckily I was as a mentor just standing next to that surgeon. So I quickly took over after the viscoelastic was put in.
Very elegant, very elegant.
Thank you, Dr. Suhas.
Thank you very much.
Are you there? Dr.
Yes,
Satyajit?
Yeah. Ma'am.
Dr. Satyajit, could you introduce Dr. Rohit?
Thank you, ma'am. It's an honor and privilege to introduce Dr. Rohit Om Prakash, who is well known and needs no introduction. Thank you, sir, for accepting the Academic and Research Committee's invitation. Dr. Rohit Prakash is the chairman for Om Prakash Eye Hospital. He's an amazing surgeon, meticulous and awe-inspiring, and he has conducted hugely successful IRSI meetings at Amritsar. His videos have won global accolades, and he has won innumerable awards with the most practical and relevant tips in enhancing learning. Thank you so much, sir. And sir will be talking on PPC, posterior polar capsule dilemmas. Dr. Rohit Om Prakash, please, sir.
Thank you for the kind words. Can you hear me, please?
Yes,
sir.
Thank you for the kind words. I would like to thank Dr. Chitra for calling me over. I would be taking up pre-existing PCR with posterior polar cataract with pre-existing PCR. I would be talking with the manual technique because this manual technique is with excess of 99.4% of surgeons. So I would not be taking up this patient with the flax technique, which happens to be a rarity with only 0.6% of Indian surgeons having an excess. So basically the first thing which we need to do is the site of the incision. It should not be parallel to the axis of the PCR. That is the first thing which we should bear in mind. Second is the side port incision. It should be calibrated enough so that there is no fluctuation in the anterior chamber. Capsular rhexis should be, my choice is an oval rhexis, because that gives me an advantage of both a small rhexis and a large rhexis. And the arm of the large axis should be at an angle to the PCR. So the large rhexis part gives me, there's no rise of intracapsular pressure, there's end-to-end sculpting, easy division, easy subincisional cortex, smooth IOL implantation, whereas the smaller rhexis part gives the advantage that one can always do an easy IOL optic capture. You can have the nuclear piece retention in the bag, and you can tamponade the vitreous as well. Hydrodissection is a big no, because that can cause an extension of the posterior capsule rupture. I did not do an inside out because it was a highly soft cataract, and I thought that I would not do it. So I planned the technique which Dr. Vajpayee has advocated, that is dividing the nucleus and the epinucleus mass into different layers, not one layer, 3, 4, or 5 layers, so that I can take them out one by one. Then when I started, you can see the IOP is less, and it will be all with the phacoaspiration, and the ultrasound will not be used. I am taking out the inner core first. And this inner core, I'm taking it out, and I know that I have 3 or 4 layers behind, which is keeping the posterior capsule rupture away from the fluidics. So I'm manipulating the angle of the probe and I'm gingerly dissociating the inner core from the outer layer so that I'm able to continue. You see how I'm not rotating, trying to just separate it in a very cautious way. So that part done. So I'm just trying now the next part is what to do next. So I'm taking out in the distal part. You just see in this distal part, there is no posterior capsule rupture. The posterior capsule rupture is here. So I will just continue to aspirate the distal part without endangering the fluidics access to the posterior capsule rupture. So now you have to keep the chamber inflated. There should not be a sudden collapse of chamber. Next step is whether I use a bimanual or a coaxial. The preferred choice is the bimanual. But if you have to use a coaxial, you have to retract it. Retract the sleeve more so that there is a different plane of irrigation and a different plane of aspiration. Another click is that I am going to shield the posterior capsule with the epinuclear mass. I will not aspirate it even when I dislodge it. So I'll go on continuing to aspirate the anterior lamella of the cortex, by which the epinucleus in the proximal part will get dislodged. Once it gets dislodged, leave it there. See how beautifully the epinucleus mass is shielding the posterior capsule. So there is no access direct of the fluidics to the posterior capsule, which can cause hydration and the ultimate consequences. So I'm just doing it very diligently, leaving an epinuclear mass. Once there is one part which is not fully separated. You will see that it is only, now once it is done, it has been taken out. There is not even one single nuclear fragment or a cortical lamella which has gone into the posterior capsule. Just for making things very clear, the next part is, these posterior polar cataracts eventually end up with an extension right up to the periphery. But I found that if you do it diligently, using the side port incision with Dr. Haldi Putkar's, micro forceps, you can bring it back even from the periphery. So for that, the chamber has to be adequately deep and you have to have stable chamber settings to complete the posterior capsulorhexis, which I was able to. I realized that this was a large, a large opening in the posterior capsule. So I just used Triamcinolone, and which I was expecting. There was no vitreous in the AC. A 3-piece IOL was introduced. I thought that I will play safe. And I used the oval rhexis to my advantage by doing the optic capture. And you can find how beautifully the IOL is placed in the center. So the surgical strategy involved is that the incision location you have to bear in mind. The sizing and aligning of rhexis is very important. Stable chamber and low fluidics is another. There should not be any exposure of fluidics to PCR. We have to do layer by layer separation of nucleus and epinucleus, strategic epinucleus and cortex removal, optic capture of IOL using the oval rhexis. Thank you very much for your kind attention.
That was an amazing video, Dr. Rohit. Thank you so much of learning in it. So let's go on to the discussion. Dr. Harshul.
Yes, ma'am. So I think as usual, Dr. Rohit always has a great teaching videos. And but Dr. Rohit, I just wanted to know, what are the extra advantage with oval capsulorhexis gives you? Like, I know there are strong proponent of oval capsulorhexis. Yes, sir.
Yeah, a small rhexis is eventually what we want to end up with. Because if required, we need to have a situation where eventually we can do an optic capture. But at the same time, we should not devoid ourselves of the advantage of having a large rhexis. So in my practice, I use an oval rhexis where I'm not confident about the status of the posterior capsule and wherever I feel that I can end up losing the posterior capsule. With the larger rim of the rhexis, wherein it is the larger rexes and we have a smaller rexes. You know, there is no building up of pressure because of the large rexes. Your manipulations become easier. You can do vitrectomy in a better way. The smaller arm helps you in tamponading the vitreous by keeping it behind. You can have an access to the subincisional cortex also. So these all things make me, because this is an idea which Dr. Kiranjeet Singh from Amritsar brought up. And I did a good study and I found that was one of the most wonderful things which he has put forth. So since the time I've started using an oval rexes, I find that this has been a beautiful invention by Kiranjeet for that matter.
Yeah. Thank you very much, sir. I'd like to add Dr. Sheetal here, who is one of the expert panel for this.
Can I add
discussion.
something also?
Yeah, just a minute. Dr. Sheetal, are you there?
She's not there.
Okay.
Himanshu,
yeah,
can I
please,
say
ma'am.
something?
Yeah, Dr. Kamal Kapoor, please.
I just wanted to say about layer by layer technique. Now, retrospectively, I think layer by layer which was described by Professor Vajpayee, and which we published way back in 2003, is something, you know, like in femtosecond cataract surgery, you have those cylinder patterns.
Yes.
We described something, you know, which is now known through femto. And I'm very glad you did that today. He's a mentor to me and to so many of us others. And I just want to acknowledge his contribution to teaching and to all of us on this Guru Purnima Day.
Absolutely.
Thank you for doing that. Thank you.
Can I add
Dr.
something?
Kamal Kapoor. Yeah, please.
I think Dr. Rohit, a wonderful presentation. I guess one more advantage of having an oval rexes is, which I discovered a few years back, and I use a lot of it in my described D technique, which is probably, I just posted a few videos a little while ago, is that like you can slip a coin through a small slit in a piggy bank box. If you have an oval rexes, you can slip out a whole nucleus out of that. You can chop within that. You can make D segments and slip out each D segment through that oval rexes. And you can also do a side chop within that D segment, within that oval rexes. So that oval rexes is really advantageous. I've done a lot of polar cataracts, which are very hard in nature. And I've chopped them within the polar rexes and taken out the D segments, sliding them out like just you slipping in a coin through a piggyback slit. You know, a big coin can go through a ovalish slit in a piggy bank. So that's another big advantage.
Kavita, can you say?
But it cannot come out from there. Once it goes in, then, you know, it's inside the piggy bank.
I think great video, Rohit. I mean, just a couple of points I might have done differently is that, you know, you persisted with the phaco probe, even with the open PC, even for the removal of the epinucleus. I mean, shows your confidence. But then I would have maybe exchanged for a bimanual IA and then gone ahead and removed all that, because especially it's a soft cataract, young patient. That would have given me much better control. And then, of course, the anterior vitrectomy, other steps, because I saw that there was a little bit of fluctuation in the anterior chamber when you were trying to evacuate all the material with the phaco probe. Otherwise, oval rexes, of course, is a great learning tip, and other things were great.
I would call on Dr. Anagha to introduce Dr. Kavita Rao. And before we go on further, I would be obliged if all the consecutive speakers do this screen sharing while the panel discussion is on. Thank you very much. On to you, Dr. Anagha.
Yeah, it's my privilege to introduce Dr. Kavita Rao. She is consultant cornea cataract surgery, Aditya Joe Hospital. Long-term fellowship at Collins Hospital, Baylor College of Medicine, Houston, and LVP. She ensured that her learning was thorough and complete, and has ever since had an extensive experience and work going on in her specialty, with multiple presence in various national and international forums. The next 4 minutes is going to display the phenomenal surgical prowess of this amazing young lady. So let's tighten our belts and watch her performance. Over to you, Dr. Kavita.
Thank you so much for that wonderful introduction. I'll be presenting two cases. Actually, they're very simple cases because Chitra ma'am told me it's like a learning video. So, but I'm just going to point out a few steps in each along the way, which will help the young budding surgeons. The first case is a patient where I'm doing a fuchs endothelial dystrophy, where I'm doing a combined DSEC with phaco. Before planning surgery, I think what's important is to keep in mind the biometry that aim a little bit of myopia for these kind of patients. Now, during surgery, what we are really going to be worried about, as you can see, the view is going to be compromised. In this patient, it's relatively better, but In a lot of other cases, you're going to be having a very compromised view because of the corneal edema. Use Tripel because not only does it stain the capsule, but it's also going to stain your endothelium, which will help with removing the Descemet's later. Removing epithelium, I think at this step is really helpful. It aids in your view. What you can do is you can aim for a small capsular excess because that will help to place your IOL in the bag later, and it's not, you'll not have the IOL popping out later when you're injecting air, because I don't really like to use myotics in my surgery. Another important tip here, I just want to stop here that, throughout the case, the only viscoelastic that, we should be using is a cohesive viscoelastic. No dispersive to be used at any point during the surgery at all, because even if a small amount remains behind, it can interfere with your disc attachment. Always make a corneal incision. Now, phaco surgery in this case, because the view is compromised, you're going to be worried about the PC rent, which can happen and it's a disaster. So after the initial split, I know most of the phaco is actually done in the anterior chamber. I'm not really trying to be go at all near the bag. You can get the pieces out and do it in the anterior chamber. Here, wanted to point out that epinucleus removal, in most cases, you would be doing with a phaco tip, but I feel this is an important point, for beginners, that you can try and just do it with your IA tips. Even though it will take longer, you can get the epinucleus out, eat it close to the endothelium, does not matter, because dealing with a rent in this case is just going to prolong your procedure, and also, it interferes with your disc attachment. Sorry, this is some editing glitch. What you now need to do, you can do this initially at any point to make an 8 mm marking. Now, how you will determine the, marking, whether it's 8 mm, usually you're going to be around 2 mm lesser than the corneal diameter. You place the IOL in the bag, make sure that it's absolutely in the bag. You do not want any of the haptics, popping out. At this point, as you can see, I have again reinforced the chamber with a high viscosity viscoelastic here, because you're doing a combined case. If you're doing only DSEK, you can do the entire procedure under saline, but with cataract, I think it's really, I think it's going to be a lot more difficult. So I prefer to use a high viscosity viscoelastic. Now with the reverse Sinskey, you're going to go and strip the Descemet's. It's very easy in a case of fuchs, but sometimes in some patients with long-standing PBK, you may really struggle. At that point, you can use a Vanna scissors or any other, instrument to help with removal. You can strip this Descemet's and make sure you take it out and, check that all the pieces have been removed. This is a very important step, that you need to remove the viscoelastic thoroughly. I have seen patients where, this step has not been done, and you see viscoelastic in between the disc and between the host cornea. Now, because this is just for beginners, the insertion, as we know, can be done with various techniques. Here, I'm just showing the very simple technique, because Dussin's glide, which I now use, requires a lot of ambidextrous, to be ambidextrous. So this is a very simple technique where you just place the, cornea onto the patient's eye and you slip it in with a bent 30 gauge needle. It's really easy. And the important tip here is that before you're injecting saline, injecting air, anything, please make sure that you are taking sutures, because even if you have a very small incision, I've suffered the hard way where it was just a 3.2 mm incision, and I've injected saline, and the entire corneal disc just comes rushing out. It's a complete disaster. Here you can see I'm injecting a little bit of saline because it just helps to float the cornea, the disc up. And now another tip I'd like to give is that the air injection initially is only through the main wound, so that you insert the cannula, go below the disc and inject the air, because oftentimes, sometimes if the view is not very good, you may end up injecting air into in the interface, and you may not even realize it till you see the patient next day, or once you've removed the air, and then you realize that it just unnecessarily adds to the steps and compromises the endothelium. You can now go ahead with a 30 gauge needle on either with a side port. You can just make a fresh entry and then inject the remaining air. So I'll move on to the second case. My second case is a patient of, it's a regraft. Just an important point here, that typically if you're doing a triple surgery where we are doing a penetrating full thickness graft with a cataract surgery, we try and do an open sky surgery. The problem with that is that you can oftentimes, it's very difficult to make a rhexis. It's very difficult, and sometimes you may have the entire nucleus and a PC rent which is just coming out because of the surgery being open sky. So what we can do is that, though this is not a very easy technique, but still what you can do is you can remove most of the corneal tissue so that your view gets improved. And even in cases with DSEC, in fact, in the next step that I'm going to come to, you can do the entire cataract surgery under a retro illumination. Shut off the microscope light and use an endo illuminator and do the rest of the cataract surgery. And you can just do it in the anterior chamber, because anyways you're going to sacrifice this entire distance. The reason to do this is because I personally feel it's really difficult to do an open sky cataract surgery. In a lot of cases you can have the entire capsule rupturing. So once you've done this, you can go ahead and put your IOL. I'll just pick that up. Yeah. Once that's done, you can go ahead and then excise the remaining corneal button, and you go ahead with suturing the rest of your graft. That's the end of surgery.
That was a wonderful surgery, Dr. Kavita, especially your second video, which had so much of learning points in it. I mean, the controlled surgery, which you were trying to explain to us, and you know how it's difficult to create. You could end up having a larger excess if you are doing an open sky and the IOL out of the bag and the PC rents and all that. So wonderful. So on to you, Dr. Harshul.
Chitra, can I ask
yes, Sujata, I wanted your opinion also.
Kavita, excellent surgery. The first surgery was really good, fantastic.
Can you be louder?
Your first surgery was excellent, Kavita. I just wanted to know whether you do an inferior PI, because you made a complete air fill. Do you normally do an inferior PI, or you burp off the air after some time? What is your take on that?
I do an inferior PI only in cases of DMEC, but in DSEC I do not do. I burp the air after 90, about a minute and a half, or maybe like 5 minutes. You just burp off the air, leave around 3/4 of air bubble.
Okay.
So Dr. Namrata, you have anything to add?
Excellent surgeries, both of them very difficult cases. I think whenever you have a case of corneal opacity or you have a case of Fuchs with cataract, the general ophthalmologist would ask a question: when would you combine it, or when would you just like to do a cataract surgery with good irrigating fluid, with good viscodispersive agents, and then see whether the cornea really decompensates or not. So I think for that, 2 figures are important, and I think we all as corneal surgeons are aware of that. 650 microns if the corneal thickness is more than that, and the cells are less than 800. So if the visibility is good, and if the corneal thickness is less than 650, cells are more than 800, you can still go ahead doing a single stage cataract surgery or phaco surgery and then see how it goes. But if the cells are less than this and the thickness is greater than 650 and your visibility is poor, then in those cases, I think you need to do a simultaneous procedure. So very good tips, and especially for the last case also, because there are chances of expulsive. You are going open sky, and if you do that controlled manner, a guarded kind of a penetrating keratoplasty, then all the issues of IOL, these doing a rhexis, expulsive, and all those things are taken care of. So the period for which your eye is going to remain open sky is going to decrease.
Yes, Dr. Namrata, very
what we can do is, you can do something like an ECC. You just put 180 degrees, cut 180 degrees of the cornea. Go ahead with your cataract surgery, just as you would do for an extra capsular case. Finish putting the IOL, and then you cut the rest of the cornea. That also can be done so that you don't have the open sky for a long time.
You have Dr. Sonu sharing his screen.
But I think if the view is very bad, like in this case, because it was a total corneal scar, probably, would you still recommend that? It would be difficult to do an ECC in such a case?
No, I don't think so, because I said you can take 180 degrees, and when you lift, you will be able to see what is going on inside. Right. You can still do a rhexis also. You can still do a rhexis, and you can wash out, you can do everything. But only thing, after putting the lens, you complete the refining, whatever you have done, you can complete the button.
Yes,
thank you, Dr. Kavita. Thanks a lot for the expert opinions. Dr. Sonu Goyal, I wanted you to share your screen.
Am I audible?
You are audible, Sonu.
Loud and clear. Yeah.
Dr. Sonu Goyal, as we all know, is a brilliant, innovative surgeon, and he's also the member scientific committee AIS and a leading beacon of light for the Rajasthan Ophthalmic Society. And I'm sure he's going to amaze us, as I was amazed when I saw his video. And we have a superb learning pearl of wisdom to know today. On to you, Dr. Sonu Goyal.
At the outset, I'd like to thank the team ARC and Dr. Chitra for giving me this invite. So,
Dr. Sonu?
Yeah, am I audible?
Yes, you're audible.
Thank you. So, challenging case, pre-existing anterior and posterior capsular rupture. So, if you see here, this 25-year-old gentleman came to us with a trauma, and very closely on the slit lamp examination, I could see there was a scar on the cornea and there was a break, both anterior and the posterior capsule. So the plan was simple, to go anteriorly, and this is the posterior capsular rupture if you see here. So I make 2 side port entries, push in the trypan, stain, and push in the viscoelastic. Now this is the breach in the anterior capsule. So a lot has been talked about the oval rhexis. So yes, my plan was to do an oval rhexis here and try to include this break in the anterior capsule within the anterior capsular rhexis. So important here is that this break is covered under or within this anterior capsular margin. That's number 1 learning. And yes, you have to be ambidextrous to fashion an oval capsular rhexis here. So I begin, this is how I initiate, go in with micro rhexis forceps, and very carefully, I'm trying to draw an oval capsular rhexis. At any moment of time, I don't allow my chambers to shallow. And here I exchange, I become ambidextrous. I try to create an oval rhexis, very carefully trying to fashion to include that breach within the capsular margin. So yes, successfully, I am able to achieve that anterior capsular rhexis. Now, plan B is very simple. 25-year-old gentleman, soft nucleus, quite aspirable. So just watch my left hand. The irrigation remains right on top of the nuclear fragments. And with my right hand, I'm trying to cleave. I'm trying to separate the nuclear fibers all 360 degrees. So I'm trying to create a saucer. And this saucer would sit right on top of the posterior capsular break. Very carefully, you'll realize a large break in the posterior capsule becomes quite visible. So yes, if you see carefully, there is a break. It's a large break. It's a large break there. Am I audible?
Yes, yes.
So watch carefully. As Dr. Namrata rightly pointed out, my left hand goes on top of the iris. I don't allow my chambers to shallow. The dispersive goes in and tries to create a barricade so that the vitreous doesn't prolapse. But still, I push in triamcinolone, try to strain and check out. And if I feel there is any residual tags, with this limited anterior vitrectomy, I can remove. So limited anterior vitrectomy with triamcinolone staining is always a must. Now, the third step is I'm trying to fashion this into a round regular posterior capsular rhexis to make the lens back complex very stable. So very careful with my microrhexis forceps, I'm trying to break and convert into a PCC. And again, a limited anterior vitrectomy helps me to take away the tags. The viscoelastic further goes in. The lens of my choice here would be a 3-piece lens. I push the lens directly inside the bag very carefully. I can use a Cook lens to support and just watch. This is what I do. I do a posterior capture. The optic goes behind the posterior capsule with the haptics remaining right inside the bag. A very stable lens back complex can be achieved in these patients. Step 4, sometimes this lens pops out. So watch my left hand, the irrigation remains on, and I'm trying to hydro-stitch the wound with the chamber being maintained. So I'm again ambidextrous here. My wounds are being stitched, and again this side port, I don't let the chamber shallow, and very gently and elegantly, I try to hydrate the wounds and maintain the chamber so that the lens doesn't pop out. This is the day 1 picture, and the patient regains a good vision. The lens is very clearly in the bag and stable. Thank you very much, Dr. Chitra.
Brilliant video, Dr. Sonu Goyal. I mean, one thing which comes obvious is The only other choice would have been to leave the IOL in the sulcus because the anterior capsule was torn. So the way he has done it, he has given the great stability to the IOL bag complex. But also, you know, theoretically, if you look at it, even the ELP is sort of assured if you do a posterior optic capture, because there is no possibility of a posterior capsule wrinkling or a contracture happening later on. So probably future would be any of these situations, a PCC and an optic capture is the way to go. Thoughts of the expert panel?
I think very well done, Sonu. I mean, the only additional point maybe I would add is that invariably there's some amount of viscoelastic going into the vitreous cavity with all these maneuvers. And once you create an optic capture, it's impossible to remove it. So what I normally do is to go with both a irrigation aspiration cannula, and before creating the optic capture, keep the irrigation cannula in the anterior chamber, and then go with the aspiration cannula behind the lens, aspirate out all the whatever viscoelastic is there. And of course, if I find some vitreous strands are getting pulled, then I will exchanging it with the vitrectomy cutter and cut the vitreous strands. And once that's aspirated, use the aspiration cannula itself to just create the optic capture. And that's a very important tip that you gave about, you know, keeping the irrigation flowing and hydrating the wounds. Actually, even before I introduce my irrigation aspiration cannula, I hydrate the main wound, because no longer you have any purpose once the lens has gone in. And that leaves me behind only with the two side ports to hydrate. And that gives me more stability. Otherwise, a beautiful video.
Great. Dr. Harshul, you have anything?
Yes, ma'am. Yeah. I think that was very nicely managed, Dr. Sonu. We all know he's a wonderful surgeon. And thank you so much for sharing your beautiful video. And before we go ahead for the next speaker, I'd like to convey my gratitude and thanks to all the gurus who are here, and to each and everyone who has taught a lot in my academic career on this Guru Purnima Day. Thanks a lot to each and everyone. And next, I take pleasure to introduce one of the most prolific surgeon of Indian ophthalmology. And he is none other than Dr. Kamal Kapoor, who is director of Sharp Sight Center. He has amazing teaching videos, and today he'll be sharing his video on iatrogenic zonular dialysis. It's a beautiful video. Dr. Kamal Kapoor, all yours.
Thank you, Himanshu. I must thank Dr. Chitra and ARC for giving this fantastic opportunity. And on this Guru Purnima Day, I don't not only thank my gurus, I thank my parents, my wife, my son, my friends, my associates, my juniors. They're all my gurus. They teach me. They teach me not just surgery, they teach me life. They teach me to have fun. They teach me to live life full. So I'll just start with my video. My video will have some very instinctive. Can you see the video? Hello?
No, we don't.
Okay, I'll just go on again. Is it
Yes.
on?
Yes.
Okay, so as the topic says, you know, simple tips for complex situations. Whenever we get a little overconfident, we're in a hurry, we make a mistake. And if a mistake is made by a mistake, I called it galti se mistake. So this is a kind of funny situation. There are no financial disclosures here. One disclosure which I have is I firmly believe in having a very relaxed and a cool mind. My friends who know me, they think I'm a very high energy person. I'm a lot of clutter headed, but deep inside, the trick is to have a very calm and relaxed mind. So this is what this video will show you. This is a situation where I'm operating a VIP patient. Mostly these things happen in a VIP. He's a politician's younger brother. He's come to me for a femtocataract surgery, and I will proceed. Everything is over. Everything is perfect. I'm in a hurry to finish it because I'm trying to show him the speed, because he's heard that probably.
Dr. Kamal Kapoor, if you can just stop the audio music from video, please.
Is it better now?
Yes, perfect.
Okay, so I'll start again. The surgery is over. Everything is perfect. I'm in a hurry to finish the case and, probably talk to the gentleman. I go in with my irrigation. You can see a femtorexis. And I just go in. I go with my coaxial area. Just watch out. See what I do. And I stop the video here. Just see what I've done. I've pulled the whole cortex along with the capsular bag and the anterior capsular rexis in. And if you actually see that, I will redo it for you. See how hugely careless I've been. You can actually see the anterior vitreous phase intact and the capsular bag being disrupted from the anterior vitreous phase. But the trick is calm mind, relax, not panic. So I go on my reflux mode. See what happens. I go on a reflux mode and I catch it again on the reflux, which means when you go on a reflux, immediately after reflux, we should slightly move the irrigation aspiration port backwards. What I did was I went in the irrigation mode and my aspiration port was nearby. So on the rebound, I caught the capsule again, but I did not panic again. I kept it there. I kept my hand steady and I remembered that I do have a left hand also. So what did I do? I'll repeat again. I used my left hand to disengage the captured capsule on the reflux. Now I use my left hand very, very gradually. I've kept the irrigation on. And as the viscoelastic is going in, now remember the viscoelastic goes in the bag, not on the bag. Oh, sorry. The viscoelastic goes in the bag. And what happens is, if you put it in the sulcus or on top of the bag, you will invariably break the vitreous phase and push the viscoelastic behind. So pushing the viscoelastic in the bag, and once you start pushing, only then your irrigation has to stop. Till that time, keep a slow irrigation on. So you will notice I push the viscoelastic in the bag and I push the subluxated part of the capsule behind. Now I fill it, but I do not overfill it. Now is the time to put in a CTR. Now, once you put in a CTR you should know the axial length of the patient and the white to white. I normally use a standard 12 mm, but if the patient is having a more than 25 millimeter of axial length, I go in for a larger CTR. The vectors of CTR are very important. You should not do a rotation movement or a tangential movement on the CTR when you're injecting, because you might dislodge it more. So I use the hook technique. I use different kinds of techniques to put in a CTR. Now this is done. My bag is stable. Now comes the second problem. Removing the cortex, which is stuck up behind the CTR. I would recommend using a Simcoe, especially in the area where there's maximum amount of subluxation. Be sure you do a sectorial removal of the cortex. Do not go in for a larger chunk. Do not be greedy. Hold out one sector apex of the cortex, triangular apex, pull it. Do not be harsh, because sometimes if you're harsh, you might end up pulling the whole bag complex along with the CTR. And now you have a subluxated bag and the CTR in the vitreous. I slightly fast forward the video here too. Now you notice the cortex gets stuck behind the CTR, so it's difficult to come out. But a very gradual pulling. A lot of times, if you keep losing the cortex, it's a good idea to let go of the vacuum and re-grasp again. Make sure when you're doing it, the bag is not collapsing. So you will notice I pull it, I re-grasp it. I pull it, I re-grasp it. Till I get a purchase on a thicker part of the triangular part of the cortex. Do not keep pushing on pulling. Pull, aspirate, combine this movement to nudge the whole cortex out. Now, I am not going to a bimanual in this stage because I am very comfortable using this. I use a lot of bimanuals also where here I'm feeling I'm able to do the job. The most tricky part probably in this situation would be the sub-incisional, where a lot of my colleagues would say, okay, you can actually use a bimanual, because for that particular maneuver, using a Simcoe is tricky, but I somehow am able to manage it. This is what I would normally do, but in case I am getting stuck up in this situation, a tip for all beginners is at this stage, you can actually go in for a bimanual. I usually would not prefer a bimanual to start with, but if you go in for a bimanual, make sure to lower your bottle height slightly because you have a huge area of loss of zonules. Now, once this is done, I've shifted to a bimanual, low bottle height, because I already filled the anterior chamber with viscoelastic, so I don't need much fluid coming into the anterior chamber. The bottle height is approximately 60 centimeter, and I'm using a lot of viscoelastic to keep my chamber filled. Once this is done, I keep my irrigation on, and then I push in viscoelastic, and then I remove. Never over pressurize the anterior chamber in these situations. Now, the angle or the direction of the lens should always be in the straight axis of the maximum subluxation. But remember, the maximum curvature of the loop has to be in the maximum area of subluxation, not your optic haptic junction. So approximately 30 degrees away from your optic haptic junction would be the maximum curvature. Now with the lens in, I go in and complete my irrigation aspiration. The whole thing is done. And each time this patient comes for follow-up, this is approximately a 2-year-old video. And this person, it comes with a lot of security guards into my clinic. Each time he comes in, invariably, I dilate this eye because for the patient, he's absolutely symptomatic. He wonders, why does Dr. Kapoor always want to dilate this eye to see? So some points to remember: never be in a hurry. This was the result of a hurry. Don't get startled. Never get panicky if you hold the capsule. Don't suddenly come out, you'll pull out the whole capsule. No jerks. If you held the capsule, keep your hand steady there. Do not give any jerks. Remember, there is a reflux mode. Your mind should not freeze. Go on the reflux mode. Remember that you have a left hand also. A lot of times when a beginner surgeon freezes up, he forgets he has a left hand. Side port viscoinflation, it has to start and then you have to stop the irrigation. Don't keep both of them on. Otherwise, you'll create a further breakdown of the anterior vitreous space. Visco has to be put inside the bag, not over the bag in these cases. CTR direction vectors we already mentioned. And the removal of the cortex, do not be greedy and try and pull the whole cortex at one time, because in this situation, you might dislodge the CTR and pull the capsular bag inside. Repurchase, in case you're not able to get the cortex in, hold it, pull it, repurchase on a thicker area, repurchase and do a gradual combo of push and pull. And always be very careful in the area of subluxation. Thank you.
Thank you, Dr. Kamal.
Thank you.
As expected, I wanted the comment of, before Harshul takes over, I wanted comment of Dr. Kaur and Dr. Suhas too.
Thank you, Kamal.
Thank you,
very, very nice management. Of course, it was managed to perfection. A couple of questions, basically, for the purpose of the learners. One, what conditions would you be anticipating a difficulty like this, and you would be more prepared and you would have some standby things available in your OT? And number two, when would you junk the idea of putting in a CTR and instead think of alternative options? How large does a zonular dialysis have to be to think of alternatives?
Okay, first of all, sir, I think on Guru Purnima day, I must, with folded hands, you're my guru. I learned surgery from you. The answer to your first question would be that this can happen at any time. You cannot actually over anticipate these things. But yes, the probability of this stuff happening in a femto case could be higher for a beginner, because in a femto, the cortex is cut flush with the anterior capsule. So for a beginner, sometimes you can end up catching the cortex and the capsule mistakenly, number one. Number two, when you're doing a topical phacoemulsification, the patient is uncooperative. You're trying to go in for the cortex and you end up capturing the capsular edge. You can have it. Number three, in case it's a pseudo exfoliation, even a slight amount of holding of the anterior capsule, you can have this problem. Number four, if you have a very small capsular rhexis and you're trying to get under the bag and under the rhexis and try and hold the cortex, you'll hold this more. Number five, if your capsular rhexis is irregular. Number six, if you're taking over a surgery from another person and there's whole cortex mixed up and you don't know where a rhexis is, because if you're the surgeon, you know where your bag and where the rhexis is. But if another surgeon's done the surgery, a lot of times I have a trouble. My junior associate calls me over the surgery. The first thing I do is I assess the capsular rhexis margin. So these situations you could actually anticipate it. Now answering your second question, sir, in case the subluxation more, see, that's what the textbook says. If you have more than 3 to 4 clock hours, you should go in for a Sionis or a CTS. That's, of course, I think for a beginner, but I've got away with more than 180 degrees capsular tears with a well-placed CTR, as long as there's no vitreous disturbance. The moment you have a vitreous disturbance, then you probably need to do a pars plana vitrectomy or a sectorial vitrectomy. I have some videos on YouTube where I've done sectorial vitrectomies from the anterior chamber. And you can actually put in a Sionis or a CTR. But yes, for all practical purposes, anything more than 3 to 4 clock hours, it's an indication that you should go in for a Sioni ring or a CTS.
And in that same, if I may ask one question, when would you put nylon hooks for supporting the capsule?
Wonderful. I think another video, I think Himanshu knows, I put another similar video 5 days ago. When I have some vitreous coming into the anterior chamber, number one. Number two, where I anticipate some chopping maneuver, which I'll be doing a lot of chopping. So I'll be creating a lot of pressure onto the posterior part of the posterior vectors, which might subluxate my cataract further and have my vitreous come up. So these situations, and a lot of situations when then I feel the visibility of the subluxation is probably far more than what it reveals. In those situations, I will use capsular tension rings and iris hooks.
Yeah. Dr. Kamal, yeah. Just 2-3 points. Why not use bimanual irrigation aspiration right from beginning first? Secondly, I would love to go in the area where the zonules are intact and aspirate the cortex first from that side, because I think that area is the stronger area. It's an area where zonules are not weak. So what are your take on this?
Yes.
Another small tip would be a circumferential pulling of the cortex rather than.
Yes.
That's what actually it said. A radial, not a radial, but a tangential pull of the cortex. I did mention that.
But as Ashul said, I would believe that a bimanual IA would do as well as there's just one other technique is how we should all assimilate this.
Yes.
So we now go on to our next
Can
speaker.
I have a comment?
Dr. Sai Kumar wants to put a point.
Yes, sir. Dr. Satyajit?
No,
Sai wants to say something, Dr. Sai.
Yeah, can I make a small comment, Dr. Kamal? Very excellent video, sir.
Yeah.
What we have, when we are shifting over to femto, we are very stingy with our hydrodissection. We are also very stingy with our rotation of the nucleus. And loosening up of the cortex is sometimes not achieved. And as you rightly mentioned, the cortex is cut flush with the edge of the rhexis margin. And so that is, I think, is one of the reasons why we may see more of catching the zonules in the early days of femto. So we are
just one last comment. I mean, I think most aspects have been completely covered, but now even from our Indian manufacturers is Henderson, Bonnie Henderson's undulating ring is available. And I find when you use Henderson that ring and put that in, then this entrapment of the cortex is
a lot easier,
obviated to a large extent. So, I mean, it's hardly more expensive than the conventional rings. And so I'd suggest that we can try that out.
Which company is manufacturing that, sir? Which company?
Both IOCare and Aurolab have it.
And does it make a lot of difference, Dr. Ramamurthy?
It does. It does.
Does it make a lot of, a perceptible amount?
Namrata, yes, it
does.
Yeah.
The other points that were emphasized about tangential stripping, going away from the area where the capsule first doing where the zonules are intact is all important. But definitely, if Henderson ring is there, then it appears to be much easier. And one last comment is regarding this, the extent where you would start using a CTR, CTS, etc. I think in a situation like this, which is entirely iatrogenic, it's otherwise a healthy eye with a healthy capsule, I'd always give a chance to endocapsular ring, and most often it would suffice. Actually, what Kamal had was a fairly large dialysis, but then it just settles down back. But if it's obviously a pre-existing condition and it's a progressive subluxation that we are trying to address because of Marfan's or pseudo-exfoliation, then all those devices would become more necessary.
Also, if the pupil is small or if the pupil is coming down, then maybe there's a greater chance that you would catch the anterior capsular rim.
True.
The other thing is you can put a multi-piece lens, because that will give even additional support than putting a single piece, which Kamal did. So in the same area, you can put a multi-piece.
Yes, Dr. Kamal. Yeah, please.
Okay. Putting a three-piece lens is a wonderful idea, but the three-piece lens by itself has got very large diametrical exertional force on the bag. And secondly, the amount of pressure, pushing pressure which I could achieve. I prefer using a lens which is opening slowly in the bag. I do not want to dilate. So with the three-piece lens, both are not true. I need to dilate into the bag. So in such situations, I prefer a rigid loop, preferably lens like an Invista, which has rigid loops and it opens slowly. It gives me enough time to let it open in the bag and they just slightly dilate in and it keeps pushing the thing back. But yes, three-piece lens is a wonderful idea, but you need to dilate it.
Yes, there are very important points which were discussed. We shall have to go on to the next speaker. Thank you very much, Kamal.
Thank you.
Excellent.
Thank you.
We shall now go on to our next speaker, a young dynamic lady, Dr. Tamilarisi. She's a consultant cataract surgeon at our Eye Foundation and is an amazing surgical trainer for all the DNBs, fellows and surgeons from the width and the breadth of our country. And mark my words, she has a very steely strength and boundless knowledge to reckon with. On to you, Tamil.
Thank you, ma'am. Am I audible?
Yes.
Good evening, one and all. Today I'm going to present on series of phacoemulsification in a small pupil eyes. What is small pupil is debatable. It can be either 2, 3, or 4 millimeter. And since pupil size is relative, the judgment depends upon surgeon's experience, the biomechanical properties of the iris, and the intraop situation. My first case is moderately sized pupil around 5 millimeter with a soft cataract. My aim was to make an adequate sized rhexis slightly larger than the pupillary margin. A gentle hydrodissection is being done. The pupil size seemed to pretty hold well, so I decided to go with the stop and chop technique. The central space created by the trench helps me to hold the heminucleus, bring it to the center, and then do a vertical chop. I didn't alter my fluidic parameters since the iris was not floppy and the pupil size didn't come down. The phacoemulsification part is as usual. It didn't differ. And while irrigation aspiration, I prefer a bimanual technique. The irrigation port helps me to retract the iris and to see the anterior leaflet in case of any difficulty. Once the irrigation aspiration is done, the IOL is placed in bag. And this is a case of small pupil where the iris behaves normally. And though the pupil size comes down by 1 millimeter, the surgery can be done very safe without any pupil expansion device. The second case is moderately sized pupil around 5.5 millimeter, and the cataract is also soft. While injecting intracameral lignocaine, I noticed a little bit of billowing of the pupil, but the patient didn't have any history of treatment for BPH. The rhexis is aimed at the pupillary margin around 5.5 millimeter, and I completed it. The care should be taken during hydrodissection, and it was gentle because that is the first inciting event for the iris prolapse. But I didn't notice any, so I decided to continue without any pupil expansion device. On start of the phacoemulsification, I noticed peaking of the pupil and iris prolapse towards the side port. Once I divided the nucleus, I start noting the iris becoming floppy, prolapse, and there was a progressive meiosis. So I need to accept the fact that I have to intervene, and I plan to use iris hooks. The situation here is different because I'm going to insert hooks after making rhexis. So the care was not to damage my rhexis margin. I injected a little bit of visco to lift up the iris, and I inserted the hooks very parallel to the iris plane and just tilted posteriorly to engage just the pupillary margin. I did not overpull the iris hook so that even if I've accidentally caught the rhexis margin, I'm not going to damage it. Since already I had an heminucleus, my job was to just hold it and chop it. I reduced my parameters from 10 to 15% of the normal because I don't want a high fluidic current inside the anterior chamber. Throughout the surgery, my aim was to keep the phaco probe and the second instrument in the center, far away from the pupillary margin. Care taken not to damage the iris and the pupillary structures. Once the ultrasound energy is activated, it causes iris chafing and the tissue fibrils, which has a tendency to get aspirated always towards the phaco probe, and it can happen repeatedly. Since the iris hooks is making my pupil stable and expanded, the irrigation aspiration and the IOL implantation is pretty easy, and the IOL is implanted in the back. Once the IOL is dialed, I just removed the iris hooks. So taking just the extra care and spending the few minutes to insert the hooks made my surgery relatively easy, more importantly without any complications, not damaging the iris and the capsular structures. While doing visco wash, always care should be taken to note for a small epinuclear fragments which can be hid under the iris, and we have to remove it. Otherwise, it can lead to chronic inflammation in the postoperative period. This is timely intervention, so safe surgery. This is another case of mine where I had floppy iris, but I proceeded with phacoemulsification. I removed a heminucleus in spite of the pupil was becoming small. The pupil became really 2 millimeter. Then I realized, then inserted hook. There was one heminucleus left. I just rotated and removed. After removing the heminucleus, there was a thick epinuclear sheet. While removing it, I noticed something abnormal. Yeah, I had a focal zonular dialysis. Now I have to insert a CTR. The capsular tension ring is being inserted in the back. So once the capsular tension ring is in the place, I removed the epinucleus and the surgery was completed. So the epinucleus is removed and the IOL is dialed in the back. So it cannot be overemphasized that pupil expansion device makes the surgery easier with less complication. Thank you.
Thank you very much, Tamal. Dr. Sandeep, are you there? Dr. Sandeep?
Yeah.
Yeah, I want your thoughts on her case as to how soon would you use your iris retractors in a small pupil case when it may not be a floppy iris situation.
Yeah, no, I would do it at the earliest instance, because if I find that even I've started sculpting and I feel the pupil is coming down on me, I would ensure that I have good visualization to go forwards. There's no point in trying to go ahead with a surgery with not a good enough view. So I would do it at the earliest opportunity. I would probably even do it after the nucleus is completed, like Suhas showed in his case, that even when he had to insert the lens in the capsular bag where there had been a PCR, so you can put in your hooks at any time to give you a better view. So definitely, I would not hesitate to go in at the earliest when I think that things would make my surgery easier. That's what I would go by.
Oh, any other thoughts, experts, opinion? Hello? Hello?
We can hear you.
Anybody has anything to add here before we go on to our next case?
I think it was nicely shown. Maybe, it's always emphasized that when you use these iris retractors, not to over enlarge them, but I would have maybe made it slightly bigger than what Dr. Tamayasi showed, because that would make it a little more comfortable for me. But more than using 4 hooks, it's always a good idea to use a 5 hooks with a subincial hook. That's what she again showed. And as Dr. Sandeep said, it's always, unlike an endocapsular ring, you use these hooks as early as possible. Once you are even suspecting IFIS, better not to get into a problem. Go ahead and use it even before you do the capsular rhexis, and that makes the entire procedure much more under control.
Safer.
Thank you, Dr. Tamal. That was a wonderful series of videos.
Another thing,
We'll now go on to Dr. Harshul Dutt, our dear member ARC Central Zone, who's also a chairman scientific committee of the Rajasthan State Ophthalmic Society. And that aside, he's a man of all moments with his versatility, which he has been displaying to us very frequently on Live Beyond the Ophthalmology Group. On to you, Dr. Harshul.
Thank you so much, ma'am. Can you see my screen?
Yes.
Okay. So I'll be sharing the tips for the young phacosurgeons as if how to take control of the errant capsular rhexis. So if you can see this capsular rhexis, so whenever you see a condition like this, that the capsular rhexis is trying to, I think somebody needs to mute themselves now. If everybody can mute, please. Mr. Sunil, can you mute other participants?
Sure, we can clearly hear you.
Okay, fine. So whenever we see a situation like this, that the capsular rhexis is trying to go radially outwards. So this is the trick by Dr. Brian Littles. First, we go and put viscoelastic in front of the leading flap. We unfold the flap and we try to hold the capsular rhexis flap as close to the root as possible and try to get the capsular rhexis forceps in the center. And you can see this capsular rhexis, it comes back in the path. Now, let's see in the slow motion, I hold it as close to the root as possible and look at the direction of the capsular rhexis forceps. It's going towards center, and always keep an eye on the leading capsular rhexis edge. And you see that this capsular rhexis comes back in the right path. And you can then easily continue by creating your capsular rhexis. So this is the Brian Little's technique of capsular rhexis rescue. I'll be showing one more video to demonstrate that again. So this is another case which had the moderately dilated pupil. And see, and this was a case which had narrow angles also. So the chamber was also shallow. See, when I'm trying to create the capsular rhexis, it's trying to slide and go outwards, and I can't see it clearly. So if you can't see it clearly, don't try to go there and hold the capsulorhexis edge. Now what I'm doing here is I just go there and put some viscoelastic. And because I need a better visibility to hold the leading edge of the capsulorhexis, I go ahead and make one small side port there and use the iris hooks and trying to take the hook the pupillary margin from the area where the capsulorhexis has not gone. So I try to get the iris hooks from this area so that I can clearly see the leading edge of the capsulorhexis. So you can't hold the capsulorhexis edge blindly. Now you can clearly see the leading edge. Again, this direction of the pull is important. It should be horizontal to the capsular plane. And you can see the leading edge is coming back on the track, and you can rescue the capsulorhexis. Again, see in the slow motion, I'm holding it, not pulling it upwards, just keeping it horizontal in the capsular plane and getting the forceps centripetally and look at the edge of the leading tear that it comes in the right path. And I can see that this leading edge is coming back on the track here. So I think every young phacosurgeon should have these micro forceps in their armamentarium, which can come handy at any time. And then I can easily complete the capsulorhexis.
Thank you very much, Harshul.
And then take off, yes. There was this small video that I wanted to share with
Thank you. Thank you very much, Harshul. Dr. Suhas,
Yes.
are you there?
Yeah.
Yeah, I want your thoughts.
Yes.
What could have happened if you are not able to retrieve the rhexis, Dr. Suhas? Could you tell us, the audience, what are the way of how you would manage the nucleus in these cases?
Well, first of all, I was always there, so question is not there. Now, one thing I wish to say before I go to that part of yours, you know, when he was showing rhexis, of course, he beautifully managed it. But I have always felt that if you're, let's say, if you're doing it with the forceps, and if your forceps, you know, starts traveling further away from the point of cut, then there are higher chances for the cut to go out. And once the the rhexis cut starts going peripherally, unless you get it in and make another inner circle, it will continue to travel and make a large rhexis. See, instead of having a 5 millimeter rhexis, if you are having 6.5, 7 millimeter rhexis, the only problem with that is that lens somehow is totally out of the bag, because the optic is naturally out of the bag. The question that you asked was, if the rhexis goes out, well, I would obviously go from the opposite end and cut it. Somewhere it has to stop. And then obviously, you want, see, as long as the cut doesn't travel to the posterior capsule, you're pretty okay. And here, with regards to phaco, the only tip I would like to offer is that these are the cases where you would do a hydro delineation and get the nucleus out of the bag. If possible, you may even do supracapsular phaco, but that's the only way you can remove the pull on the tear.
Yes, yes, Dr. Suhas, I exactly wanted to hear that from you. And anybody else? Anything?
Just make a comment.
Anaga, yes?
Yes.
Great videos, Harshul. Great videos.
Thanks.
Yeah, I just wanted to say a few points. One is, I think probably sometimes if the chamber is a little shallow and the anterior surface is not very flat, then there is a greater chance of it moving to the periphery. So maybe if we can actually put in a viscoelastic and flatten the anterior capsule, number one. Number two, may not go in through the main incision, but only through the side port so that you don't open up the main incision. So there's less of viscoelastic coming out of the eye. And as Dr. Haldipurkar rightly said, holding it at the edge when you are actually cutting it. And then maybe just in small sectors, like just one clock arc each, holding it back again, one clock arc, holding it back again, so that you are having a very, very controlled thing. And I liked the way you actually used the iris retractor and then pulled it so that to increase the visibility. The only point is you're an excellent surgeon, but just by chance you had somebody had pulled the rexus edge also along with it, it could have been really disastrous.
So
that only
that's why
shows your dexterity and the great control that you have.
That's why it's important that you come from the area where you know that you're not gone that side, you know.
Yeah, maybe
and the points here, what I wanted to highlight was the direction of the tears, which are very important to take care, because these are situations which arises, you know, only sometimes when we are not that, we are in a hurry and we are not taking care. But we should recognize that no, it is going outwards. You need to, you know, rectify this.
Yeah, absolutely. Mainly, probably in a case where the pupil is not really very well dilated, you can plan for a slightly smaller rexus in the beginning, and keep the edge of the rexus parallel to the pupillary edge at each time, so that you prevent and avoid such a situation in the first place. But very well managed.
Another point that I would like to bring out is that sometimes you are able to, those were excellent tips. Sometimes you are not able to view the edge that has started when you started your maneuver. But if you have a clear feeling that the rexus has been initiated, go on with it. Don't leave it in the middle. Just keep a centripetal pull, and you will find that you will continue around and come towards the center eventually. Because if you leave it in the middle, then you would have abandoned yourself to a broken rexus. But if you continue and you feel that you have started a rexus, you are very easily able to maneuver it towards the center in the visible zone.
Just a clarification, Harshul, I mean, you of course managed it beautifully, but the classical Brian Little maneuver is supposed to be, you put the flap back and pull it in the direction in which you have come. That is, if you're traveling from 5 o'clock to 6 o'clock, doing the rexus, and at 6 o'clock it's running out, you put it back and again pull it towards the center and towards 5 o'clock again. So you're not going to put it back, and that is supposed to drag the rexus back towards the center. Of course, most often just pulling it towards the center and towards the apex of the cornea itself helps. But then again, pulling it back in the same direction in which you have come is supposed to give you even better control. And that is the classical Brian Little maneuver.
Yes, sir.
Thank you for very valued comments. I'm sure it's been great learning in your video, Harshul. You're amazing as ever.
Dr. Chitra, 2 points, small 2 points.
Actually, we are running out of time.
Okay.
No speakers are there, sorry. We shall now go on to Dr. Sheetal Brar, who's a Senior Consultant and Research Director of Netrama Hospital. Quite a path blazer she is, with her absolutely amazing sequence of best ASCRS videos year after year. And she's also an amazing smile surgery and refractive surgery trainer, and has trained over 75 national and international surgeons, and has over 40 publications in index journals, besides many more. And she is going to actually give us a very basic tip, something's going to be something which all of us have come across time and again, and how to troubleshoot IOL implantation. On to you, Sheetal.
Thank you, ma'am, and thank you so much for inviting me to this wonderful webinar, and happy Guru Purnima to all the wonderful and great ophthalmic gurus, Suhas sir, Ram sir, Chitra ma'am, Namrata ma'am, Kamal sir, all of you. You know, I've been learning cataract surgery by seeing your videos, listening to your lectures in various conferences. So thank you for teaching us. So I will be giving a very basic tip, and I'll be showing you about how we can have problems during IOL implantation. And essentially, I'm sharing 2 videos to show how an IOL can get stuck in the wound. And this is a situation we don't really face very commonly. And once in a while, you may encounter this problem. And I'll be showing how to, sorry. Yeah, I'll just start it again. Okay, so how can an IOL get stuck inside the wound? So it could happen if your technique of IOL implantation itself is faulty, or if there is a sudden eye movement from the patient side. So this is situation number 1, wherein I'm trying to implant an IOL. So this is through 2.8 millimeter clear corneal incision, and I'm putting a hydrophobic intraocular single piece IOL. This is a screw type injector, which I'm using. So essentially, this is the Technis 1 injector, which we very commonly use. So just watch very carefully. So as I'm advancing the lens and I'm doing the screwing movement, there was a sudden jerk. So due to this jerky movement, what has happened is that the cartridge has actually come out of the wound. And since the IOL was already unfolding, it has now got stuck inside the wound. Now, this could be very tricky and you have to be very careful. So first thing you should not do is do not try to manipulate the lens, because your AC is very shallow right now. And the first thing that you should do is to inflate the bag. So if you try to maneuver the lens, you can have an inadvertent PCR. So inflate the bag using a high viscosity OVD from the side port, form the bag nicely. And now, depending upon how much of the IOL is already inside the anterior chamber, you can decide. So in this situation, 1/3 of the lens is inside the chamber. So you can use a non-tooth forceps and pull the lens out of the wound. So since most of the lens was out of the wound already, it is easy to actually use a forceps and take it out. And then you can use the same lens and reload it in the same injector and inject inside the eye. And the case ended uneventfully here. This was first situation. So situation number 2 is again, I'm using the same lens, same injector, but this is a toric lens now. So similar situation arises here. So I'm doing the screwing movement. The lens is advancing. And as it was just about to release, and you can see again, there was a movement. So basically it is the problem with the technique. You have to stabilize the injector properly and make sure that the lens is fully inside, and then try to take the hand out. And then now in this case, because most of the IOL was already inside the anterior chamber, you can use a pusher or a Guggen hook to gently push the lens inside the anterior chamber and the bag. And then you can use the same instrument to rotate the lens as well. So the very basic tip which I want to give here to the beginners is that when you are using these injectors, it could be the screw type injector or the pusher type injector, it is very important to stabilize the injector, especially the front part of the injector. So you have to stabilize it and then only start your movement, the screwing movement or the pushing movement. So if you stabilize it properly, then this complication, the chance of having this complication is minimized. And always make sure that you actually visualize that the whole lens has unfolded and has come out, and then only try to withdraw your hand. Because if you prematurely try to withdraw your hand thinking that the lens is out, then also IOL can get stuck inside the wound, and then you can have this kind of a problem. So these were very, very basic tips. I think for the beginners, they would find them useful.
Very valuable tips, not just beginners, to all of us, Sheetal. You brought some very relevant points home. Essentially, all of us need to remember that the anterior chamber has to be kept stable with viscoelastic before you start maneuvering. Arshul?
Yes, ma'am. Yeah, Sheetal, those were very good videos. And, we all of us come across the situation like this. The only thing is that we should check the integrity of the corneal wound once the case finishes, because we have done some struggling with the corneal wound. So it's always better to check the integrity nicely. And even if required, we may put one suture so that, we don't have the leaking wound. Otherwise, yeah.
Just a comment.
Very well managed. Yes, sir.
Very simple but very instructive video, Sheetal. My observation is that this is more often likely to happen when you're doing an wound-assisted implantation, when you're trying to limit yourself to 2.1, 2.2 millimeters. But obviously, in both the cases, I noticed the mouth of your cartridge was inside the anterior chamber. So it was not a wound-assisted implantation. It's less likely, though occasionally because of the patient movement or something, it can happen when you withdraw. And in this case, I think the plunger type injector has an advantage, because when you're doing the screw type, both your hands are sort of occupied. But if you're using a plunger type, you can use a Sinskey hook or a second instrument through a side port, stabilize the eyeball, and then gently push it in which case this kind of it opening up outside is less likely. And other thing I do is to create an adequate incision. Earlier, I always used to do a 2.2 millimeter. Now I almost completely shifted to 2.4. And that allows me to get a good purchase on the cartridge on the wound and stabilize the eyeball with the Sinskey hook, and then this kind of issues obviated, not that it never happens.
Thank you, Dr. Sheetal. Thanks a lot for being there.
Chitra, I think two people, Sai and Anagar, were wanting to comment quickly.
Can I make a comment, sir?
Yes, sure.
Yeah. See, what I have noticed is once in a while, some of these slightly used injectors and plungers actually override over the lens.
Yes.
And that is when once you go in and you see that the plunger is almost fully screwed, but the lens wouldn't have, totally gone into the eye. So I think checking for the, the integrity of the tip of the plunger, in some cases, that is what I have noticed. Excellent videos, Dr. Sheetal. Thank you.
Thank you, sir.
Can I just make a quick?
Yes, Anaga, tell.
Yeah, sorry, ma'am. Just make a quick comment. Great videos, Dr. Sheetal. I just had a few points to say. One thing is probably when we are actually injecting the lens, the tip of the cartridge was well inside, but as we start screwing in the lens, inadvertently we probably tend to retract. So the tip comes, closer to the wound, and probably at that point of time, the patient must have moved or some jerk. So what I tend to do is before I start injecting the lens, I tell the patient that now we are going to inject. So please keep looking at the light and do not move. So he's also more cooperative at that point of time. Second thing I noticed was probably the anterior chamber was slightly shallower and there were just some folds on the cornea. So maybe we could just inflate the chamber more, deepen it a little more, and then more consciously be a little more inside, so that once the tip of the cartridge is well inside the wound, then there's a less likely chance the lens would get stuck in the
but the thing is that the jerk happens very suddenly when you just don't realize it's happening.
So we tend to retract the tip. So at that point of time, and we should stop screwing. So once you are already screwing and the tip is also out, both these points will cause a lens to come out into the wound, I think.
Yes, Anaga, very valid points brought forth. So we shall now go on to our next speaker, Dr. Sandeep Navnekar, a very dear friend and yet another very innovative and brilliant surgeon from Mumbai with a very meritorious career, with a fellowship in cornea under Dr. Tom Cassay, with a very highly reputed private practice and a teacher to many. He's going to give us a tip on a very rare situation, a sort of how he has dealt with a cosmetic blemish which could have far-reaching complications. On to you, Dr. Sandeep. Dr. Sandeep?
You need to unmute, Dr. Sandeep.
Dr. Sandeep, you have to unmute. Somebody should.
I'll just call him.
Yeah, call him.
Mr. Sunil, if you can unmute him.
Is that okay now?
Yeah.
Yes.
Okay, yeah.
Okay, yeah.
Yes.
So at the outset, first, I would like to bow in reverence to many of our speakers, our colleagues, the experts out here who have taught me so many things. And on this Guru Purnima day, I would take this opportunity to thank all of them. I would also like to thank you, Chitra, for this wonderful opportunity. So here was a case where this was a VIP patient, Manu, and I was doing a trifocal toric implantation and using a femtolaser. So you can see I've come to the end of cataract surgery. You can see the well-constructed rexes. Nice.
Sir, you need to share your screen, sir.
Share. But
okay.
The video is...
He's paused it. He's paused the screen.
Yeah.
Okay.
Yes, Dr. Sandeep.
Yeah, so I just paused it for a minute only.
Yes.
Can you see my video now?
Yes.
Yeah, sure.
Yeah. So, okay, fine. So you can see the rexis is well centered on the visual axis. You can see a nicely constructed femtolaser incision. Everything looks okay. I think I'm just a few minutes away from closing the case. But what I was totally unprepared for was what happened later on, you know. And as you can see out here, I am I'm injecting the lens into the eye. Mind you, it's a preloaded trifocal toric from a very reputed company. And as you can see over there, I've come to this stage where it is in the eye, the lens is completely damaged. So what do I do now? The first thing, of course, is that I have to remove this IOL out of the eye. I cannot keep it over there. So the second thing was that I have to probably go ahead with my original plan. So let's see what we did. So first injected viscoelastic. Then through the side port, I introduced a forceps, an IOL holding forceps, which is a 1.2 millimeter duck-billed shaped IOL holding forceps. And in the help of micro scissors, I went into the main wound and I started slowly disassembling the lens. The thought plan was that if I'm going to put a trifocal toric in this patient's eye, I should not enlarge my original 2.2 millimeter incision, nor should I allow it to get distorted, because if I allow it to get distorted, I might increase the surgically induced astigmatism, and that might preclude me from getting the best possible result, which is desirable in all these cases where premium IOL has to be carried out. So I was very careful that I did not enlarge the incision. And the other thing that I noticed was that because this is one of those hydrophilic lenses with a hydrophobic exterior, their refractive indices are high. So these lenses are low rather. So these lenses are very thick. And you have to be very careful when opening the jaws in the anterior chamber so that you don't damage either the cornea or the posterior capsule. So slowly, very slowly, I went ahead and I completely disassembled the lenses into 4 pieces so that each of those pieces was small enough to be got out of the eye without damaging the endothelium and without altering the size of my wound. And finally, I heaved a sigh of relief when I got that last piece into my forceps and slowly dragged it outside the eye. So this was the first case. And I'll now just come to the second case to give you a brief overview of this case. This case was a case of an artificial cosmetic iris implant, which a patient had implanted elsewhere. And this patient landed up with some secondary glaucoma and some corneal decompensation in the periphery. So his angles were closed and definitely this implant needed to come out of the eye. So let's see how we went ahead with that. So I made a side port, first of all, a 1 millimeter incision, and then I injected first a dispersive viscoelastic, followed by a cohesive Healon 5 under the viscoat so as to ensure that I had a proper soft shell technique. Mind you, this was a young 29-year-old male. And then with the 3 millimeter angle teratome, I went in and made an incision in the anterior chamber. I just enlarged slightly the inner lips of that incision. And then using the same OVD, Healon, I injected a little under the cosmetic iris implant so as to create a space between the iris implant and the native iris. Then using micro scissors, I made 2 radial sphincterotomies, 180 degrees opposite to the main wound. Now, this was essential to have some grasp on the iris. So this is something which I thought would do well. I once again made sure that I had a lot of viscoelastic so that I don't. Then we held with the micro forceps, again, the same forceps which I used to hold the IOL. And then very, very slowly and without lifting it, we basically made sure that all the haptics and as well as the foot plates got disengaged from the angle. And we started removing the iris implant outside the eye. As I realized the chamber is getting shallow, I had to regrasp. And as you can see, the iris was getting dragged out. So I said, no, this should not happen. I should once again make sure that I inject viscoelastic so that the iris does not come out of the wound. So through the side port, I went in again and injected some viscoelastic to keep the iris away. And finally got this silicone implant, which is a 11 millimeter implant with a 3.5 millimeter pupillary aperture. And I got it outside the eye. Thank you so much for your patient listening.
Excellent, Dr. Sandeep. That was a very nice video. And the way you did visco protection in the second case, actually that was a different thing which you don't normally see. And I understand that there's an anterior folding of the implant which can happen, which you beautifully prevented by making those nicks and bringing it out. But I just wondered, could you have myose the pupil? Do you need to do that before you start the procedure?
Yes, I did. In fact, I forgot to mention, I did inject carbachol in the eye first. That's why the pupil was so small. Yes. I had to, because initially when you saw the patient, you only saw the implant. You never saw the original iris at all. So if you have to go there, you might suddenly accidentally touch the lens. So the first thing which I did after making the parasite.
Yeah, these are inflamed eyes. You could even have a peripheral anti-cyanican, or maybe even a visco injection underneath also.
Yes.
The implant which you did do.
Correct. So the first thing I did after the paracentis was inject myocol. And then after that, I injected the viscoelastic, try to deepen the chamber. And again, I tried to create a space between the iris implant and the native iris so that I could put my scissors inside and cut. Now, each of these patients brought some other patients, and I've done about 5 such eyes like this.
So Dr. Sandeep, are you into taking out, or are you also putting the iris implants?
No, only taking out. I don't advocate.
Yeah.
I don't advocate.
Why I asked you this question was that iris implants the world over are creating a lot of problems.
Correct.
Endothelial decompensation and secondary glaucoma is very common.
Yes.
So most of the surgeons these days are the ones who are taking out the implant rather than putting them in.
No, I am one of the ones who have taken out.
I'm one of the ones. I've put one in and taken 4 out.
Yes. I mean, the one which I did came from Delhi, by the way.
What is the specular count for these patients, Dr. Sandeep? What are the specular counts? Specular counts did you do for these patients?
Oh, this patient had already developed a specular count of 900 and he had a localized corneal decompensation. So we had to get it.
Sir, which is the forceps that you're using to hold the lens?
Yeah, I was about to ask the same question.
Yeah. That lens holding forceps is very good.
What is the side port forceps which you're using?
The lens holding forceps?
This is not imported. In fact, I made Indo-German make it for me.
Oh.
Indo-German Surgical Corporation.
It goes through even the side port, sir? It goes through the side port?
Yeah, you have to enlarge it to about 1.2, 1.4. See, you have got a duckbill, so it has a good hold. If you take a normal forceps, it will not hold.
It won't hold like that.
You need that little hole in the tip so as to be able to grasp that IOL well. Then
in fact, a short comment here. Yes. Yeah. I've used this Indo-German instrument, both the lens holding and the cutter.
Yes.
And I've compared it with at least 7 other companies which make it, both Indian and foreign, but nothing like this Indo-German holding forceps.
It is the best.
It's the best I've seen so far.
Yeah.
Just a short comment, Sandeep. I mean, the second case is unique. I mean, I at least have not seen these implants, thankfully, or nor explanted them. But as far as the first case is concerned, you handled it very elegantly. But I'm wondering whether the take-home message is that it should be cut into 4 pieces, because I find that even if you create one quadrant cut, you're able to rotate the lens and take them out to a 2.2 or a 2.4 millimeter incision, even if it's a hydrophilic lens. And secondly, the way to avoid this is most often I feel that it occurs when there is some resistance and the lens is not going in freely, and you push the lens inside and opens up all broken up. So I think whenever I feel some resistance in implanting the lens, I immediately stop implantation, reload and reposition the lens and then go ahead. That cuts down the incidence of these complications.
Absolutely right, sir. In fact, I learned to comment about your second point. In this case, what happened is it was a preloaded lens. So it was just given into my hand by nurse. I did not, in fact, was involved. So they are the ones who put a little visco, close it and give it to you. And I did encounter a little more resistance than normal. But even that little more should have alerted me. It was my mistake. I should have probably stopped at that time. I thought it is okay. It's a preloaded lens. If it's a preloaded, prefixed by the company, nothing should go wrong. But yes, it did go wrong. And to reply to your first point, yes, I have done those. I've even removed 6 millimeter IOLs by just making a simple cut in the iris and getting it out. But that leads to distortion of the wound architecture. And when you're putting a trifocal toric, you want to make sure that your surgically induced astigmatism remains where it is. I mean, my surgically induced astigmatism is 0.1 using the centroid value of Barrett through a 2.2 millimeter temporal incision. So I wanted to make sure that I do not enlarge that incision. And that's the reason I made 4 pieces, because one, I wanted to make sure that I don't touch the cornea. The second thing, I didn't want a distortion in the wound architecture as a result of the surgery, leading to more astigmatism and a less than acceptable result. So in this case, before I took up I just removed the IOL. I had to wait for some time to get the new, trifocal toric, which was not. not with me in stock. It took me about an hour and a half, and then I did it again. And thankfully, the patient is enjoying 6/6 partial and 6 vision today unaided. So I thought that was because, and that's what I wanted to show, it's maybe better to make it into multiple pieces so it becomes easier to remove out without distorting the wound architecture.
Thank you very much, Dr. Sandeep. But we are running late. We have 3 more speakers. We have already crossed our time.
Yeah.
So we have to limit our discussions henceforth.
So 4 speakers.
Now go on to Dr. Sanjay Chaudhary. Dr. Anaga,
Yes,
Dr. Sanjay, could you share your screen?
Yeah, it's my privilege to introduce Dr. Sanjay Chaudhary. He is the chairman and medical director of his chain of I7 hospitals at Delhi and NCR, a prolific cataract and refractive surgeon with very many firsts in premium live surgical demonstrations. And we are truly lucky to have him amidst us today in this sea of learning. Besides his prolific leadership qualities, he has also innovated the Game of Thrones at the AIOS, which is gripped with drama and surgical fest. So over to you, Dr. Sanjay Chaudhary, sir.
Thank you, Anaga, and thank you, Dr. Chitra, for giving me this opportunity today. So what I'm talking about is a little more advanced steps in the management of a posterior capsular rent. So here you see a posterior capsular rent with a lot of cortical matter still inside, and this is a typical puncture of the posterior capsule when the phaco tip hits the posterior capsule. Now the question was, how do I prevent this rent from moving towards the periphery, and how do I do the minimum of manipulation to get a good acceptable outcome? So the first step that you see, which we do in any posterior capsular rent, is to stabilize the chamber with an anterior chamber maintainer. So what you are seeing here is an anterior chamber maintainer, which is attached to a bottle height of 30 centimeters, which gives you an IOP of about 24 millimeters of mercury. So at 24, your chamber is stable at all times and you can do all the maneuvers that you want. So now I'm going to show you the anterior chamber. ACM is in place. The chamber is stable. I think the vitreous is disturbed. It should be disturbed. So my first step would be to stain the vitreous with triamcinolone and do a vitrectomy. Now I'm doing an anterior vitrectomy, but ideally is to go through the pars plana route these days and do a vitrectomy from behind and pull the vitreous behind. That gives you more chances that this rent will not extend to the periphery. However, here also I was lucky that I could contain the rent, but let's see how I managed it. So a little vitrectomy behind the plane of the posterior capsule rent. I bring the instruments out and you see the chamber is so stable that I don't have to push in viscoelastic from the other port before I bring my instruments out. Now another trick, I'm using a vitrector in the IA cut mode, a 23 gauge vitrector, and in the IA mode, it works like a bimanual irrigation aspiration system, and in foot pedal 3, in the cut mode, it works like a cutter. It cuts the cortical matter along with any attached vitreous strands so that there is no tug on the vitreous and the retina. So chances of CME or retina problems are minimized. Now, once this cortex cleanup is clear, and if you, as you see, my next target is, can I do a posterior CCC and round off the edges so that this rent does not run out? So I have one, again, I'm not doing this under a viscoelastic. I'm just doing it under the anterior chamber maintainer. And hold this anterior capsule from the tip and pull it in to round off one edge. This second edge also needs a little rounding here. So I'm rounding off this second edge. And I think I have a fairly controlled posterior capsule to put in an implant. Now the next question is, what implant? Do I put an implant in the bag or do I put an implant in the sulcus? In this situation, I could have done both because I had controlled the posterior capsular rent, but I decided in favor of a 3-piece IOL in the sulcus. And notice this 3-piece IOL is also being injected under cover of anterior chamber maintainer. And if you notice, when I'm putting this implant in the eye, I want the chamber to be a little harder because just 24 millimeters of mercury chamber is not a hard enough eye for my maneuverability within the eye. So I raise the bottle height from 30 to 40 by 10 centimeters. The eye becomes a little more firmer and I can put the IOL in the eye. That is one. Number two, this IOL should open in front of the iris. Because if you try to directly put it into the sulcus, the chances is that sometimes it could dip and go back into the vitreous and disturb the vitreous, or it could fall back into the vitreous. Once opened in the sulcus, you can easily dial it into position. And once you have dialed it into position, you can do a comfortable posterior capsule. So you fixed it to the posterior to the anterior capsule, and the lens is central. It is in position. There was no risk of the vitreous falling into the vitreous cavity because you're not used, visco falling into the vitreous cavity because you're not used the visco at all. So the risk of secondary glaucoma or inflammation in the vitreous cavity because of the visco falling in the vitreous is negated. So it works out well, and the technique doesn't seem to be too complicated. It can be easily done by everybody.
Thank you very much, Dr. Sanjay. Excellent video. Dr. Harshul?
Yes, ma'am. Yeah, Dr. Anaga.
Yeah, that was a great video, Dr. Chaudhary, and great learning tips from that. Actually, it was a very good demonstration of how you actually converted that PC tear also into PCC. One thing, yes, probably if we had used a viscoelastic, it would have given us greater resistance to do it. It was the great surgical prowess which was demonstrated here. And one thing I wanted to ask is, in the presence of an AC maintainer, do you think there could be greater hydration of the vitreous instead of using a viscoelastic? What extra advantage otherwise you think you would have? Because unless, of course, obviously, if there's a retained viscoelastic, that would cause more inflammation and greater IOP arise. Any other advantage that you see by using a AC maintainer? And do you think there could be an extension of the PCR also in the presence of an AC maintainer instead of using a viscoelastic?
See, it really depends on how much pressure you build up within the eye. That is one. And if your anterior chamber maintainer is just generating an IOP of 21 to 24, which is almost a physiological IOP. So suppose you have a PC rent and you have vitreous there in a normal eye, and the aqueous is there in the eye. It does not mean that the vitreous is getting hydrated and coming out into the anterior chamber all the time. So if the pressure is low, it will not push into the vitreous and hydrate the vitreous and bring it up. But if the pressure is high, it would do that. So that is why it has to be attached to a bottle height of 30. Which is giving you an IOP of 21 to 24. Then the vitreous does not get hydrated.
Yeah.
Can I make a
I
point?
think Dr. Sanjay, that was very beautifully shown and very well managed by you, Sanjay sir. I think you take off, when you use the ACM maintainer, you take off the use of the irrigation cannula, which we put from the side port while doing vitrectomy. And also, it definitely gives an advantage that you don't need to put viscoelastic again and again when you go out. And then you can use the same vitrectomy on the cut IE mode as you have shown beautifully. The only thing is that when you're putting a 3-piece IOL under ACM maintainer, I think if you are very well versed with the 3-piece IOL, then only you should use it. Otherwise, that time you can at least you use viscoelastic to put a 3-piece IOL. And in this case, I think you could have put single-piece IOL also in the capsular bag, because I think the PCR was very well managed and it was converted nicely. It was looking pretty good that you could have implanted single-piece IOL also. Only the 3-piece IOL, I'm a bit skeptical about putting.
Yeah,
under,
so your points are well taken.
Yes,
your
sir.
points are well taken. See, the issue of when you're putting the lens in the eye, you need a firmer eye.
Yes, sir.
That is why we use viscoelastic to make the eye firm so that we can put in the lens comfortably. However, whatever viscoelastic you will put with a large PC rent, it will fall into the vitreous and have its effect. So what we do here is that when you put an IOL in the eye, at that stage you raise the bottle height. You make the eye firmer. And once the eye is firmer, you can comfortably maneuver the lens into the eye. If you notice, the 3P lens did not give me trouble while I was putting it in.
Yes. I know, I'm sure it went off very well and it didn't give you trouble at all because you are very skillful, sir. I'm just talking about the majority of the surgeons.
A second point which I wanted to highlight was that once you do a posterior CCC, there are 2-3 things you have to keep in mind. One, you have to increase the magnification of the microscope. 2, you have to increase the illumination of the microscope. And 3, the most important point, it has to be 100% retro illumination.
Yeah.
Only then will you get that kind of a glow that you can see the edge of the rhexis margin of the posterior capsule tear, hold it and turn it around. If you saw, the visibility was very clear.
Yes.
But then you need a fairly large pupil. A small pupil, you will not get all these things. Because a small pupil will reduce your visibility.
Thank you very much, Dr. Sanjay. That was an excellent presentation. I would request Dr. Srinivas Joshi to introduce.
Madam, just one quick comment I just wanted to make. Sir, actually, Sanjay sir, very beautiful video, and you nicely showed how to avoid viscose because it definitely goes out into the vitreous cavity. But one point I just saw, sir, that while injecting IVTA, I think a little bit more IVTA went into, and you are lucky that dipping the cutter down, you could get that blob of the IVTA which was mixed in the vitreous cavity and it came out. Why I'm mentioning this is we had certain few cases where the IVTA goes down and then the patient comes back with the increased IOP where we have done even vitrectomy in those cases. I think that is one point which all of us have to be aware that inject a little, because anything more than 2 milligram of IVTA is definitely going to raise the intraocular pressure.
Point taken, yeah. That is why they say it's better to go through the pars plana route and clean up the vitreous. It makes a much better sense.
Much better. Thank you.
On to the next case.
I have a pleasant task of introducing another dynamic surgeon, Dr. Sujata Mohan, madam. She's a highly accomplished who has been very extensively qualified with exposure at great training centers and packed with phenomenal surgical skills in cataract, refractive cornea, and glaucoma. And she has been a recipient of many awards and accolades. But what's more important and what caught my eye was the Nari Shakti Puraskar Award. It's one of the highest civilian award for women. She received it by the President of India at Rashtrapati Bhavan in March 2019 and made Indian ophthalmology, women Indian ophthalmology as well as men Indian ophthalmology very proud. Thank you, madam, that it was a good honorable moment for all of us at ophthalmological moment. And she's been a great teacher, and that is where she's here to present a great teaching pearl. Over to you, madam. Looking for it.
Thank you, Dr. Srinivas. And at the outset, I'd like to thank Dr. Chitra and the ARC for giving me this opportunity. And over this past 1.5 hours, we have been having a great learning experience. And each and every surgeon, the amount of surgical skill they have shown is really phenomenal. And I'm so glad that I was made part of this wonderful webinar. So my topic is on showing an iris encerclage in a patient with an Uret-Zavalia syndrome. This was a 40-year-old high myopic female who had an AC phakic IOL done 15 years back. This was a refractive IOL, the Verisace model, which we used to do 15 years back. And post-operatively, she had a high intraocular pressure, which resulted in a fixed and dilated pupil, something like an Uretzavalia syndrome. But patient had 6/6 vision, but the only problem she had was a significant glare. She refused any further intervention because she was very happy with her vision. She didn't want to go back in for doing any iris repair. So she's been coming for regular follow-up over several years because she had the eyes done, both eyes. One eye is absolutely normal, only this eye developed this. And over the 15 years, then about 6 or 7 months back, she developed cataract. And she was posted for IOL removal, iris repair with phaco. So this is the video showing video. Yeah. So this again is showing the same history, and so you can see that the lens is a little bit dislocated down. I'm making multiple entries, side port incisions, and disenclaving the iris. It came out very nicely, very easily. And once I disenclaved, I made a clear corneal tunnel, about 5.5 millimeters, so that I can remove the IOL. This is an all PMMA IOL, so it cannot be cut. It has to be removed only in toto. And I removed it. And at this point, you see that the cataract is about grade 2 to 3, and completed the rhexis. Because the patient was a little bit younger, you can see that the capsule, anti-capsule is quite rigid, something like a pediatric cataract, but I was able to complete it using the rhexis forceps. And a routine hydrodissection, gentle hydrodissection all around, and rhexis, and made a central crater, rotated the nucleus, did a anterior chopping, vertical chopping. It was a standard case, and because the patient was a high myope, had a deep AC in spite of so much of fluid leaking out from the side port, and completed the phaco uneventfully, did the an IA using the coaxial method, polished the capsule, and planted a +3 diopter multi-piece intraocular lens into the bag. So far, so good. I think someone is talking in the background. They have to be muted.
Mute everybody, excepting me and Harshul.
Yeah, please.
Yes.
Okay, now what I'm now trying to do is I'm just checking to see if I'll be able to continue with, just leave her alone. Inject pilocarpine to see if it is constricting. It didn't constrict. I've been following this patient. I know she's not going to constrict. So I'm just testing to see how much of iris I can pull. So the question is whether I should do an SFT or go with an iris encerclage. I decided to do an iris encerclage because that gives a fairly normal size pupil. You can see I'm using a 10-0 Prolene needle. And you see that I'm using the microforceps to actually tag the iris onto the needle. So the needle is stationary, but the iris is forceps is grasping the iris and tagging it on. So the bites are actually made multiple times. It's better if you make them very closely, which I really didn't do, I should have done. And at every point, the microforceps is actually coming into play with very little action from the needle. Then it's exited. So wherever it's not possible for you to go around, you exit and then re-enter through the same wound. And use the microforceps to the maximum help, and you tag the iris at every point. And the superior portion, this area, there was some amount of fibrosis, so it's sort of cheese wired, though I try to do it repeatedly. And went all around and exited. At the point of exit, I'm using a 26 gauge needle to railroad it so that I don't catch on to the corneal tissue. So that's also very important. And then now I have, I'm tying the suture. You can see in some areas, there's some amount of cheese wiring has happened. And several ways of tying can be done, but I've just done the tying outside and removed the pieces, and it's become sort of a little bit round, not bad at all compared to what she had. And post-operatively, you can see that she had a fairly reasonably round small pupil, about 4.5 millimeters. And the area where the iris is cheese wired, you can see the suture was covered by the lid. So her glare came down significantly, and her vision also improved to 6/6, and she was extremely happy. The one thing I could have done here was probably could have resutured this area, gone back inside and resutured this area. But the advantage of doing this type of iris encirclage, what I find is that when compared to an SFT is that it is much more, it looks more physiological. The whole iris, this was how the case looked, and this is the post-op. So iris encirclage is more of an elegant procedure for atonic pupil, because the pupil, when it comes down, it looks more physiological. And the important tip is to keep the anterior chamber deep. Use a good viscoelastic. I prefer viscoat, no financial interest, and keep the needle stationary. So, and you keep the microforceps, which keeps tagging the iris onto the needle, and take the needle along like a running suture. It's practically running suture, and take very close bites. So this is a learning experience for me, though this surgery I did about 1.5 to 2 years back, though I've said 6 months in this. 2 years, and subsequently when I've done it, I've taken very close bites. So when you take closer bites, you get a very nice round pupil. The one point you have to remember is some of this iris could have, over a period of time, could have become very rigid. So that can actually cause a cheese wiring. And so you have to take at least 1 millimeter into the iris tissue to prevent cheese wiring, and make multiple entries to facilitate the sewing angle. So you can even go around. If you want, you can even shift your chair from the temporal to the superior side. And every time you exit and enter, make sure that you don't catch on to the tissues at the incision, because then the whole point goes away. When you try to suture, you'll find that your suture is stuck in one of the corneal tissues. So that's a very, very important point. And knots can be tightened either using the technique which I showed, which I did outside, or you can use the same McConnell retrieving technique. It's called as a McConnell-Ahmed technique, where the combination of this encirclage along with the McConnell's retrieval technique can be used. And then other important thing is you do the visco washing under the IOL before suturing, because once you suture, you may not be able to go under the lens and wash. So then the rest of the viscoelastic can be washed after the iris encirclage has been done.
Wonderful surgical presentation, Sujata. It was just amazing. A lot of learning, very different from the each surgery has been very different and unique. The only question I can ask, if at all, if I rack my head, is could you have done a scleral tunnel to get the vericize out? To maybe, though your corneal incision was not too corneal too, just one thought, that's all.
Yeah, it was limb, but I didn't do, practically, even for my DSEC or any of these surgeries, I prefer a limbal-based corneal tunnel, because I don't want the bleeding. I hate doing a scleral section and then doing a cautery, and I mean, probably a little bit of laziness, but this tunnel it's quite stable actually. You can see that it was a very strong tunnel because it's more limbal than corneal.
Thanks a lot. Your encirclage tip was also amazing. I mean, it really would have been a tip for many people who have not started it to do it. Thanks a lot, Sujata. I would request Dr. Satyajit to go on to introduce Dr. Praveen. Dr. Satyajit.
It's an honor and privilege to introduce Dr. Praveen Subodhi, a second generation ophthalmologist, a young and dynamic faculty. Dr. Praveen is a cornea and refractive consultant at Ruby Eye Hospital in Behrampur in Orissa. He has made several presentations, national and international, and he has several publications to his credit. He has a video pack with the essential learning steps of phacoemulsification, and he will be speaking on phaco in white cataract. Dr. Praveen Subodhi, please.
Good evening, everybody. First of all, I would like to thank Chitra Madam for giving me this opportunity. And on this occasion, I would like to thank all my teachers for giving me good pearls to learn phaco and to become what I am today. To start with, I would like to say the secret of your future lies in your daily routine. So a routinely performed cataract surgery in a normal way will help you to have a secured future. This is just a routine and a mature cataract phacoemulsification, which I'll be showing. The first thing I would like to say in a mature cataract is a wound construction. It needs to be watertight so that there will be the constant collapses of the antechamber will be less. So you can see here, when you stain the capsule under the air bubble is not coming out. This is a sign that the wound is watertight. And you can see in this, on staining the capsule, there are certain elements of pseudo-exfoliation. If you have a pseudo-exfoliation, you need to be careful while performing phacoemulsification. For the sake of youngsters who are starting phacoemulsification, in a pseudo-exfoliation, the chances of jonular dialysis is very high. And second, in cases of pseudo-exfoliation, the nucleus is comparatively harder than a normal case. And as I start my capsulorhexis, I make a small flap. You can see here the fluid is coming out, liquefied fluid. You need to remove the fluid so that there happens a clear visibility of the entire capsule. And you need to be very careful while performing capsulorhexis here, because if it goes out, it is very difficult to retrieve, and there is very high chances of posterior extension of the rhexis and leading to a nucleus drop. And when you perform a capsulorhexis with the help of forceps, you need to be very guarded, you need to be very controlled so that you can have a guarded opening, the required opening which you want. Ideally, if you have a good opening of 5.5 to 6 millimeters, then half of your job is over. So there are main two things. 50% of your work, 50% of the job is over with a good wound constructions, and another 50% of your job with a good capsulorhexis. If you do a small capsulorhexis in cases of a mature hard cataracts, there's every chance you have to use a lot of energy while removing the nucleus. You have to use a lot of vacuum while removing the nucleus pieces, and that may lead to jonular dialysis. So good capsulorhexis is very, very important. And once you do a capsulorhexis, a good free rotation of the nucleus is very, very critical and crucial to make your job very much easier. If you're not having a free rotation, you need to ensure that the rotation has to be done. Here, I'm doing a small superficial trench. You can see here. The reason of doing trench is two reasons. One thing, I can gauge what is the density of the nucleus, and second, the central hard part will little bit soften up so that when I do a chop, it can easily break in the center. So this is very, very essential to do a little bit of trench. So once you have a trench, then you can have an edge to hold the nucleus properly. You can see here, I'm holding the nucleus now tightly and going to the equator. You need to go to the equator. It is better to go to do a horizontal chop because you'll be cracking the weaker part of the nucleus, that's the peripheral part, and then coming to the central hard part. That makes the nucleus, centrally the nucleus will be broken into two pieces. If you do a vertical chop, there's a risk that you put more pressure on the jonules. And in a horizontal chop, the pressure on the jonules is very, very less. You can see the nucleus is cracking from the periphery, and once it reaches the center, it also cracks very nicely. The second thing, as you know, in a pseudo-exfoliation, the endothelial decompensation is very high. The endothelial compromise is there. That's why you need to break the nucleus into multiple pieces, as many pieces as possible. Just like a pizza, you can have 8 or 10 pieces so that you can use less energy while removing the nucleus and emulsifying in the antechamber. So once you break into multiple pieces, then it is easy for you to use very less energy to emulsify the small pieces. this, you can see completely the nucleus is coming out very easily without any stress on the zonules. So finally, placement of the nucleus, nothing more to say because already been said by a lot of speakers. So thank you very much for the kind attention.
Thank you, Praveen. That was a fantastic teaching video. Every word of it had so much meaning and value and thought over. I think unless there is some question to be asked, we shall go on to the last speaker, Dr. Sai. Dr. Sai Kumar is another star from South, consultant cataract glaucoma from Giridhar Eye Institute, and is a very popular figure in his parts for his surgical skill, his approachability, his leadership quality. And let us see what he has to tell us about this evergreen challenge of Argentinian flag sign. Dr. Sai, can you unmute? Mr. Sunil, can you ensure he's unmuted?
Yeah, I have unmuted.
Be unmuted.
I'll just share my video. Can you share my video, please? Can you do that from there?
Yeah, we can see the video.
Your video is visible. You need to start it.
You need to start it.
Yeah. Okay, so I'm just showing you two different types of Argentinian flag sign. The first one is as you make the first nick itself, the entire capsule splits. So here the split is along the horizontal axis. That is, if you're sitting temporal, it is along your horizontal axis. And normally these Argentinian splits don't go to the periphery. This was a very, very soft cataract. And with just phaco aspiration, I was able to manage this case easily. This is a 3-piece lens that I'm implanting. These 3-piece lenses will go into the bag because only 2 areas in the bag are open, but these 2 flaps needs to be trimmed, and so I do what is called a hemirexis in this situation. 2 cuts along the opening in the anterior capsule and make it just like a rexis in both sides, and you have 2 hemirexes and a very well centered intraocular lens there. This is the second case where once you start the rexis, the first flap is there. You've made one turn, about 2-3 clock hours of turn. And just when I thought I could get away with it, then I have an Argentinian flag in the opposite direction. So this is where you are in slight trouble because you're sitting temporal and you have an Argentinian split which is along the vertical axis. So you have to manipulate this capsule a bit before you can proceed with phacoemulsification. So this hemirexis, what I did after IOL implantation in my first case has to be done before IOL implantation in this case, because otherwise it makes your phacoemulsification extremely difficult, and there is every chance that you might injure the anterior capsule while doing your phacoemulsification. Now, needless to say, the anterior chamber has to be filled very well with a good dispersive viscoelastic before you do these maneuvers. Now, regarding phacoemulsification, my idea was to gently chop, but then with hold, this was manipulated into the anterior chamber. I initially thought of doing a supracapsular phacoemulsification, but the nucleus was not very hard, and with good viscoelastic cover, I was able to do a phacoemulsification in the anterior chamber. After making a few maneuvers, you get this feeling that I can somehow get this out without chopping and without much of maneuvers. But this patient definitely had some DM folds the next day. Probably this is one step which I could have avoided in this sort of situation. So anyway, with good viscoelastic cover, I was able to maneuver this piece into the anterior chamber and do a phacoemulsification. Now, once the nucleus is cleared out, then again the cortical aspiration goes on just like in any other routine case. And as I mentioned before, and as has been the experience, I'm sure of most of the surgeons here, the Argentinian flaps, although the opening is very, very rapid, usually they go and stop at the zonules. very few of them become a wraparound tear. But once it becomes a wraparound tear, obviously, then your your technique has to be totally different. And this again goes into the bag. Well, the two areas of the hemi-rhexis that you've made will safely, you can tuck in the haptics in those two areas. And the open area of the capsule will be in the opposite meridian to the haptic. So this is my two videos regarding the Argentinian flag sign.
Thank you very much, Dr.
Thank you, Dr. Chitra, and thank you, ARC, for this wonderful opportunity.
Thank you. Dr. Suhas, you are there? Could I have a comment of yours? Dr. Suhas?
I think Suhas sir
I think sir is not there.
Left. Yeah,
Yes.
he is left.
So, anybody in the panel who wants to comment on this case, which has been...
I just have one question to ask, Doctor.
Yes,
Just wondered, because the second case, it was very obviously intumescent. Why didn't you use one of those newer techniques to prevent this?
No, normally, normally I do a double rhexis in all these situations. I do a small rhexis and then, decompress the bag and then go in with a second rhexis. But sometimes, when you do that first turn, you get this feeling that, I can get away with it, or maybe, I can finish with such slight spiraling. You can get a slightly normal size rhexis. So, but as I made the first turn was obviously unpreventable. The moment you touched, it just split open. Second one, as you said, with slightly more care, probably it was a preventable Argentinian flag.
I think, like Dr. Ramoti said, when you have a shallow anterior chamber and so much of water clips, very high risk of Argentinian flag sign, because once you have a shallow chamber, you have to look at some other means of avoiding it. The other question is that the rhexis, it was such a sharp rhexis going beyond the area of the iris that run away. Don't you think there's a good chance it would have gone to the posterior capsule as well?
Yeah, I mean, this is one observation that I have made, over the years, that most of the Argentinian flags usually don't become wraparound rhexis. I'm not sure whether this is the observation of the other surgeons. I personally feel that it is because of the split is sort of symmetrical and the forces are carried almost in a symmetrical fashion. If you have a single point rhexis runoff, the chance for going to the periphery and becoming a wraparound is much more than when you have two opposite quadrant runoffs, which usually goes and stops at the zonume. Of course, the chance of a wraparound tear is always there, but in most of the Argentinian flag sign cases, initially, the moment I saw an Argentinian flag sign, I used to shift to an SICS. But then these very soft cataracts and all, SICS is actually more messier compared to a phacoemulsification. So of late, I have sort of observed that most of these don't run to the periphery.
The only tip we could have in this, not in your case, generally in an Argentinian flag sign, that IOL injection, if it's a 3-piece IOL, it should be injected onto the iris and then dialed into the capsular bag, rather than injecting a 3-piece forcibly into a capsular bag with so much of rhexis runoffs. Maybe
that point is well. Yeah, thank you.
So any other points before we conclude?
So I think that was a very important point made by Sai and brought about by Sujata also, that whenever you have a single point of weakness, that is when it tends to wrap around, whether it's an Argentinian flag sign or any other kind of. Sometimes when you lose the rhexis, sometimes it's even a good idea if you're not able to get a circular rhexis. Even doing a age-old can opener is a good idea, because that creates multiple points of weakness, and then the chances of it wrapping around to the posterior capsule becomes much less, because the whole it's distributed equally all across.
Yes.
Just a concluding comment. A small comment, yes. Again, it may be a repeat, but yes, it is worth trying this new technique which is being advocated, that you put in a bevel 26 gauge needle, not from the central but the paracentral area. Let it go in and suck out the cortical matter. It will just decompress the bag, and the chances of getting an Argentinian flag sign are reduced dramatically.
Oh, Sanjay, absolutely. I mean, it's a very important and a great presentation that was made. It's just that in spite of all these maneuvers, sometimes you end up with a problem.
You still have it.
Then how to deal with it.
Perfect.
Yes. I do realize that most of our speakers have stayed on right till the end. And thank you so much, each and every one of you. I do believe that this webinar was truly good because though the videos were aimed at being simple, but there were some fantastic pearls which came across. And it has been truly a talent show of greater skill and valor. Thanks a lot, Dr. Ramurthy and Dr. Namrata, who stayed on the fair end of it. My most endearing ARC panel, who have always been a very strong support for me, and a terrific, awe-inspiring panel of speakers, amazing. And Ayers, Kripal and his team for their constancy in support. Mr. Sunil for putting the webinar together so seamlessly, despite the fact there were so many videos to be shown. Entoad, which we especially need to remember, who have been very generous and have supported every single ARC program as sponsors. Mr. Sai from Numerotech for being that unstinted support. And finally, my dear attendees, for your presence and encouragement to take ARC forward. Thank you very much, one and all of you. Thank you. All of you, links do stay connected and take it and go, because it was really a superb talk of each of yours. Thank you.
Thank you, Chitra. A very well conducted seminar.
Thank you, everyone. Thank you, everyone.
And humble namaskar to all. They were true gurus today and gave us so much of enlightening pearls of wisdom. Thank you.
Even you gave good pearls, Anaga. You did very well too.
Thank you a lot, everyone.
Thank you.
Thanks, Harshil. Bye.